And I would argue that health is fundamentally important to achieving the educational agenda as well. So I think that this is a foundational issue. It's a pillar for the future, which makes this work incredibly important. Yesterday, Governor Hutchinson also said that, I think his term was, you got to begin by doing an inventory. He talked about beginning with a clear understanding of where we are and where we're starting from. And so again, looking at this through the health lens, I'd just like to show some statistics which may be very familiar to you or may not be very familiar to you. According to two large, well-recognized measures of overall population health, one called America's Health Rankings by the United Health Foundation, another, which is the County Health Rankings Initiative that is conducted by the University of Wisconsin Institute for Population Health in partnership with the Robert Wood Johnson Foundation. According to both of those methodologies, Arkansas is 49th in overall health among the nation's 50 states. And I've listed just some of the categories. There are more categories here. 44th in diabetes, 47th in cardiovascular death. Our own Department of Health, Dr. Joe Bates, has done an analysis. Our rate of cardiovascular death in individuals between the age of 45 and 64, peak times of productivity, is twice the national average. We're 50th in stroke. Our mortality rate in stroke is 60% above the national average. We have a high rate of cancer death. We're about 30% above the national average. And then we have some process measures here: obesity, smoking. Argument as to whether obesity should be considered a disease. Some say it should. Some say it's causative. But obesity certainly contributes to disability associated with back pain, osteoarthritis, and disability, heart disease, stroke, diabetes, and multiple cancers.
Dr. Ron, can I just ask you a question about this? So you
Only
mentioned,
one.
Okay, I can't make any promises, but you mentioned the CMS projected growth of 5.9% or so, which I know we talked about some yesterday, and we've had some projections from the Stephen Group about the impacts that's going to have on our budget. Obviously, from a national perspective, if they're projecting somewhere between 5 and 6%, would you say because of our overall health ranking, we could expect to be on the even above that?
That would be my expectation. I think one of the reasons why we find a per capita cost that's high in a variety of different insured populations is because the burden of illness is higher. We know that prevention is less expensive than treatment, and our health care system is largely downstream of a lot of these root causes. So that's a very big issue, and so I think it's important for us to focus upstream.
I do too, and again, I think it's so important for the legislators here to understand what we're hearing here is that we saw yesterday from the actuarial presentations that we may be $1 billion short in the next 5 or 6 years, even with expansion savings, and that's optimistic according to what we're seeing here with regard to public health. So we've got some real challenges if we don't do something.
Well, Dr. Ron, while we're on that, because this prevention versus treatment issue is so huge, can you just overview in a minute or so the difference between the way prevention is handled when the private market is dealing with health care in terms of covered expenses, et cetera, and the way prevention is handled when you're using a government-run fee-for-service approach?
I'll do my best, but let me give a bit of a disclaimer here. I'm a chancellor. Nobody knows what a chancellor does. In general, our knowledge is a mile wide and an inch deep. So there are people who are more knowledgeable about the specifics of everything you're going to ask me than I am. But in general, more and more plans are moving toward identification of risks and engaging enrolled individuals in programs that reduce their health care risk and providing financial incentives. The University of Arkansas's health plan involves a health screening requirement. I had mine, had my height, my weight, my BMI, my blood pressure, my cholesterol profile, a fasting blood sugar, and then because we don't trust people, we believe in trust and verify, a test for whether I have any tobacco in my system. And by going through that screening process, risks are identified and programs to reduce my risk are offered to me. In addition, my health insurance cost is lower if I participate in the screening and participate in the in interventions. So that's a plan design. It's a smart plan design. There's more of that ongoing. We generally see less of that in publicly funded health plans, but I'm not the expert on that. I do believe that what is necessary is to align my incentives as a participant in a health system, right, an employed individual at UAMS, my incentives responsible for UAMS's budget, my incentives is with responsibility for the health system and its viability at UAMS, and my incentives for society. We need to align these incentives through plan design and through interventions if we're going to make headway.
And again, I don't want to belabor this too much, but I think this is an essential example of the difference between the way public, government-driven stuff happens, not because public-driven or government people are bad. That's not the reason it happens. But the reason that the private market identifies what works and prevention is smarter and all these other things and comes up with these innovative approaches is because the profit incentive forces them to continually choose better options. So this is what I'm going to call a very hard to quantify but significant soft benefit of this shift toward making things more private market oriented. Now we're going to find out, Doctor, whether the government will change the law for us by waiving the things that prevent us from doing some of these smart things, and hopefully we'll be able to get a broader approval to do the kinds of things you're talking about.
I want to emphasize, thank you very much, I do want to emphasize this is 2014. These data are pre-insurance expansion. It'll be interesting to see what the next round of data provide. But the summary message here, in my opinion, is that we're starting from a position with lots of upside opportunity. Lots of upside opportunity. I also would maintain that the cost of this profile, both as borne within the healthcare system and as borne in terms of lost productivity in society, is really staggering. I can't quantify that, but I would maintain it's very large. So why is this? It's really complicated, and that's probably, to some extent, explains why we've been moving on a pathway that's been so resistant to change, despite the fact that everyone would like to see it change. This is a construct that's adopted by my colleagues in the College of Public Health, by our public health colleagues in the Department of Health, that fundamentally the structure and function of our health care system is really important and is one of the foundational elements for addressing these issues. But so are behavioral factors, social factors, and issues related to the physical environment, be it an urban environment, be it a rural environment. And there's a very complex interplay between the causative factors that are typically seen to be external to the healthcare system and those issues that are within the healthcare system. It's the orientation of the United States healthcare system toward dramatic successes when illness has occurred, rather than an orientation toward the core drivers of the poor health that has led many to say that the U.S. has more of a sick care system than a health care system. And it's one of the main reasons why the United States as a healthcare system doesn't profile favorably compared with other economically developed nations. It's not that there's something wrong with our capability in dealing with acute illness. We are the best in the world at being able to do that, without question. It's the fact that we don't have a system that has focused incentives toward the other primary drivers of abnormal health. So this is a really complex problem with many interrelated parts. Everything's connected to everything else in one way or another. What we do know is that what we've done to date has gotten us to where we are. Right? That's a bit of a truism, right? Whatever's happened up until now has gotten us to where we are. We can surmise then, if we keep doing what we've been doing, nothing will change. So we've got to have some new thinking. We've got to have innovative strategies. We also know that this situation has been coming on for a long time. This has been coming on for decades, and change won't occur overnight. It's going to take persistence, it's going to take patience, and it's really going to take an all-hands-on-deck. This is not something that the public sector can solve on its own. This requires all stakeholders to be involved. But you as a task force, I believe, have a really unique responsibility and opportunity because of the attention that's being focused on these issues today. We really are at a crossroads. Either we change the game or we don't. And if we don't change the game, then we'll be back here next year looking at the same kind of statistics, and the next year, and the next year, and the next year. And we can expect that the trends that have been operating will continue to operate. So where do we begin? We don't want to let this complexity say it's just too much, right? You don't want to let the perfect get in the way of the good. We don't want to get in the trap that because we can't do everything, we can't do anything. We've got to start somewhere. And I do believe that the place to start, although the drivers are not primarily within the healthcare system, I think the place to start is within the healthcare system. And working on strategies through reform of the system and change in payment methodologies that focus everyone upstream and incentivize individuals toward achieving the goals that we have in society at large. We need success for the participants in the system, patients, families, communities, the success experienced by employers, the success by the components of the provider community, and success as seen by society and leaders to be seen the same way. As long as I'm responsible for UAMS and I'm reliant on patient care revenue to advance the mission, which I am today, 75% of our budget, I have a fiduciary responsibility to ensure that we maximize our patient care revenue in excess of expense, because that's how I support research and education that is otherwise unfunded. We need to be participants in a system where we help work to reduce expenses, to reduce transactions, to reduce cost, and then share in the savings. Then I can carry out my fiduciary responsibility in a way that's aligned with overall goals of reducing the dollars that flow through the healthcare sector and reducing expenses. So if we do this in a way that's fair and efficient, I believe we can achieve lots of savings. And I'm just going to focus on a few issues, as I said, and also on ways in which UAMS is engaged in this process, and to invite you to think of UAMS as a resource as you go forward. So if we're looking at fundamental issues in the acute care system, where I believe about $2 billion of spend is between physician services and hospital services, what can we do there? Well, we got a primary care environment, we've got acute episodes that occur, and then we have special populations. I look at these as three different buckets, and I have read, I can't say I've read every page, but a lot of what's in the most recent report from the Stephen Group really kind of parses this the same way. And we've got strategies. We've got strategies that can help move toward a focus on these drivers of ill health and reduce expenses through an approach involving patient-centered medical homes, episode-based payments, and health homes for special populations. Now, the words can get confusing. A patient-centered medical home is not a building. A patient-centered medical home is a care model. It's a care model in which the focus is on engaging patients and families as partners, changing payment to be aligned with outcomes at the population level. Population level being, does every healthy individual get their influenza vaccine if they should? Do I get my colonoscopy, which I'm pleased to say I've had 2 of? Do I check my blood pressure when it needs to be checked, my cholesterol? Do I exercise with regularity? Those are kind of screening population interventions. Reward a practice for achieving those outcomes. Within the practice, there are going to be individuals with hypertension. Does everyone with hypertension get seen when they should be seen? Are they on an appropriate regimen? Are they achieving blood pressure targets? Right? That's a different kind of population. So the focus of a patient-centered medical home is to develop the competencies and capabilities that are required to take an approach to being accountable for achieving the right outcomes for the entire patient of populations served through that practice. This requires a team of care. It requires redesigning how dollars flow, moving away from a dollar flow in which the doctor is paid by the number of billable transactions to a dollar flow that's focused on achieving the outcomes for the patients in the most efficient way. So it's aligning payment with population health goals, putting in chronic disease management strategies for diabetes, hypertension, asthma, the high-impact common illness, wellness targets, et cetera. In order to engage patients as being effective participants in this, they have to understand their role. We talk a lot about patient responsibility and patient accountability, and that's really, really important. But we have to make sure that we have enabled them to understand what their role is. This is not meant to be pejorative, but we have found that we need to get our communications from UAMS to a 5th grade level or below frequently in order for patients to be able to really understand what the issues are. Still, one of the most frequent complaints that we have from patients is that their problems have not been adequately explained to them. So a focus on patient literacy and health literacy is a big issue. We've got a Center for Health Literacy at UAMS. Also, engaging different kinds of people in the practice, like community health workers, is a very important strategy. We don't have a process in Arkansas for certification of community health workers, a really big issue. We've got a prevention research center in the College of Public Health. The prevention research center is looking at the role of community health workers to really engage patients and families. All of our practices, as have many other practices, been converted to patient-centered medical home models. Electronic medical records have been installed. There's a lot of infrastructure here. Continuing down this pathway is really important. Episodes of care, there have been 15 episodes so far that have been developed collaboratively involving providers and the payers. And every episode that's been in place for more than a year here in Arkansas has resulted in either reduction in actual costs or reduction in costs below what was projected. By adopting guidelines collaboratively, using best practice as known within the literature, by engaging stakeholders and saying, this is the way to treat an upper respiratory infection, this is the way to do a total hip replacement, this is the way to treat heart failure, we find that we can reduce expenses by trimming outliers. There's a lot more progress that can be made there. And then this other issue of special high-cost populations, genetic diseases, Down syndrome, children with complex medical problems. A health home initiative through Arkansas Children's, led by Dr. Dennis Quo, is having remarkable success and better outcomes for children and lower costs through creating a health home that would then that also utilizes tools like telemedicine to manage children in an ideal way. I mentioned Down syndrome. That's a common problem now. There are right ways to manage it, but any individual practice is not going to have many individuals with Down syndrome. So you've got to have the expert input then carried out through the delivery system, through partnerships, utilizing other tools. Lots of opportunity there. And behavioral health is a real quagmire, as we know. About 50% of expense is associated with the 5% most complex individuals with behavioral health disorders. Failure to effectively manage them contributes to our homeless problem, ends up in the hands of the correction system, drives correctional costs. A strategy that involves endorsing a health home approach to behavioral health disorders, complex ones, is really important. Telemedicine, I just asked the leaders of our Center for Telemedicine to tell me what's going on right now. And on the left-hand side here is what's going on. We have among the best infrastructures for telemedicine in the country.
Doc, I just want to make sure, it says 3 core strategies, but what you really meant was 3 ways of describing or 3 ways of using or 3 states of progress for the patient-centered medical home model, correct?
No, what I meant was focusing on patient-centered medical home, episode-based payments, and health homes for special populations are 3 core strategies.
But they're all part of this concept of shifting from a fee-for-service, you know, if you come in and put stitches in my hand, I pay you, into a thing which says, I'm going to judge outcomes of populations and pay based on that. These are all different varieties, different stages of us doing that, but the
Yes.
one big idea in here is the patient-centered medical home, call it what you will.
Yeah, that's, and payment methodologies that provide flexibility for the provider to design the way to achieve the best outcomes. And that moves upstream toward patient engagement, towards some of the other issues that have been so thorny. And give flexibility to the providers to figure out how to engage their patients and families within their environment, how to make sure that readmissions are reduced in the treatment of heart failure. How, in all of these categories, more flexibility and a shared savings approach by achieving better outcomes, I think, is a very positive way to go. And telemedicine's a tool. I mean, I'll finish up quickly here. We're doing a lot of different things with telemedicine on this infrastructure, but we are only scratching the surface. You passed legislation this past session that changes payment methodology and invites broader use of telemedicine. Telemedicine can be used in an enormous number of different ways for specialized conditions, for the acute interventions like stroke, to move images associated with trauma, which we are doing, for the provision of specialized obstetrical services to high-risk patients in a distributed way, through which we have reduced perinatal mortality and improved outcomes. We have over on the right a whole variety of different initiatives that are underway right now that use telemedicine as a tool. This is a resource. This is a resource, particularly the combined Representative Collins with payment redesign, that can enable us to extend expertise so that zip code is not so important in determining health outcome. It is a fact that where you live is as important as your genetic composition today in determining what your opportunities are for good health. In leveling that playing field, very important in a state with 48% of the population living in rural areas, telemedicine offers tremendous opportunities. And then finally, something I put in here for Senator Hendren, just because I wanted to suck up to him a little bit. The UAMS College of Pharmacy, you've talked about this on a number of occasions. The UAMS College of Pharmacy has a program that's well established for evidence-based prescription practices. And with the expertise that's within that team, we've saved the state $28 million last year for the state health benefit plan. There's a lot more that can be done. There's a lot more that can be done in that arena.
But what is the essence or the difference between evidence-based prescription drug programs and the normal way we do it everywhere else?
Really should have Dwight come and talk with you and take some time for that. But there are things called reference-based pricing that can be used. There is therapeutic substitution, where if an expensive medication is prescribed, but there is a therapeutically equivalent medication that's less expensive, what will be paid for is the less expensive medication. Patient can choose to pay more themselves. There are guidelines for expensive medications. A tricky one that we're dealing with nationally right now is medication for hepatitis C. Very effective, very expensive. Who should get it? Why? What are the conditions? So it's implementing guidelines for decision-making in what is the largest growing cost sector in healthcare today, which is prescription drugs.
But what you described is pharmacy benefit management, isn't it?
It is.
Okay.
Okay, before we continue, Dr. Ron, we got a question, and I got a kind of a request of the task force members. I've had a couple texts. People are having a hard time hearing up here because we got a lot of side conversations going on. So I'm just going to ask you all, if you have a conversation that you need to have with fellow legislators, take it in the back here so that these folks who want to hear this stuff and can keep track of it. Senator Rice, you're recognized for a question.
Thank you, Dr. Ron. You mentioned a while ago, and I've heard some from the correctional community and some other areas. You mentioned the possible savings of mental health versus corrections. Is there anything from the medical part that I've not personally heard of? I've got somebody sitting right here may have something, but do y'all have any studies or any background what percentage of people that you think realistically can be helped, and I'm looking at because you're sitting there, Central Arkansas has such an impact on the state. Is there anything that you can give us in a way of percentages that you think, because we're looking for savings to move from one place to another, and that's should be a big one.
Again, I personally can't give you a target number, but our researchers within the Psychiatric Research Institute at UAMS have specifically looked at this from a health system delivery standpoint, and we would be able to probably at least give you a framework for how to think about this. One of the jobs that I had prior to coming here was as the president of what was then the Medical College of Georgia, and in that role, we had responsibility for the health care for 60,000 inmates through an interagency agreement. It's one of the paradoxes that we received more money to provide health care for the inmate population than we did to educate and train the next generation of health professionals, but that's another story. And I learned during that time, at that time, the single largest category of pharmaceuticals within the prison system were antipsychotic medications. It's a large problem, and in some ways we can look at this as postulated failure of other systems coming to home in a very expensive setting. But I think we can provide you with some guidance there.
And let me just say, Senator Rice, we did have one hearing on prescription drugs and heard from UAMS and from some of the Pharmacy Association, and we probably will do that again. Unfortunately, the news wasn't as good as far as potential savings as it was for the state employee and the teacher's plan, but there is still some work we can do, and we'll get some folks in here to speak to that. We've got.
Thank you.
Do you have another question, Senator Rice?
Okay. So I know I'm running long here. So other issues. This is just a little bit of a review for you of some things that UAMS has done. We have a series of, so obesity is a huge issue. The Rockefeller Institute is leading a statewide planning process right now to develop a statewide strategy. That'll be coming forward. That's very important. Health professions workforce, I've listed some new programs that we've launched at UAMS during the time that I've been chancellor. It's a big issue, addressing the health workforce needs, but we're actively working on that. What about the frail elderly? I was surprised to learn that in Arkansas we have a disproportionate number of individuals in institutional settings rather than community settings. You funded with tobacco settlement funds the creation of aging centers around the state through which we deliver a national model for caregiver education. It's a replication of the Schmeeding methodology that was developed through the Schmeeding Center up in northwest Arkansas. We have a geriatrician and we have a resource for caregiver education within 60 minutes travel time of everybody in the state. No other state has that. That's not linked right now to a really integrated, formalized approach to support community living for frail elderly. I don't know how many of you are dealing with this right now. My wife's aging parents are in Augusta, Georgia. She's an only child. Her mother fell, broke her hip, broke her shoulder. Her father has Alzheimer's disease. It is really difficult to navigate these systems and maintain community living. There's a lot of headway that can be made there. Then there is the issue of prescription drug abuse, which I'm just going to kind of go by. So a big issue, as you know. It's my understanding that although we have 5% of the population, we consume 90% of the world's oral narcotics. Is that correct? I think that was in your report. Stunning problem. So that contributes cost, and it contributes to other forms of substance abuse, and again, we end up in the prison system. So we have lots of pieces, lots of things that are going on that really haven't been brought together under a comprehensive umbrella. And I think that's really what you can do. It doesn't mean state-run, but an understanding of how all of these various things fit together and how, if we put our emphasis in the right areas, we can get the greatest impact on health and the greatest impact to reduce expenses, both avoidable expense and actual cost. But we got to know where we're going. You know, everybody's got their favorite Yogi Berra quote. I like this one. I also like the one that says nobody goes there anymore, it's too crowded. But you know, if you don't know where you're going, you'll end up someplace else. We have to be really focused on what our goal is, what our destination is. And I would put as the destination this being in the Western Division that our goal should be #1 in the SEC, in my case, in health. So, thank you.
Okay, we've got several questions here, and I'm going to let Senator Teague, who came and gave me a question, because he and I are the only ones old enough to, I think, to were back here when we did a tobacco settlement 15 or 20 years ago, and we spent tens of millions of dollars trying to decrease smoking and the diseases related with it in Arkansas, and we see that we're 48th in smoking today. So I guess what I would ask you is, that's the concern that I think many of us face is we spend money and we don't see results. Do you all are you prepared to bring to the task force either things that have proven results in other states or that you feel confident would actually produce results? Because
Yes.
this is hard to defend.
Yes.
You do.
You said, am I prepared to do that? Yes. Yes. Now, I will bring, we have a center in the College of Public Health, and I'm prepared to have them come, and we will be able to talk with you about what's been done, what has worked, what hasn't worked, and what we should do.
And I guess that's what I would ask for some help.
We've got this
from you
whole new
from
problem
task
now of vaping, right? We've got the whole new issue of e-cigarettes being a gateway to actual cigarettes.
I mean, each of these that you've identified on this, we're 49th over on all these that were in the top 40s here. I guess that's what would be helpful to us is what are your all's recommendations on how we move those numbers from 48th to 35th and then on up the road? What changes do you, from health professional standpoints, bring to this task force as far as recommendations? Because then we're going to come back in 5 years and see if you've been right.
That's fine. I'll be gone by then.
Okay. Okay.
So we'd be happy to do that. And as I said, we got to begin somewhere, and I think we need to begin, within the healthcare sector. And I think there's a lot of creativity and there's a lot that's going on right now that will bear fruit if we stay the course, having to do with payment redesign.
Okay, we've got 5 on the list here, so let's go through these. We'll start with Representative Gates. You're recognized.
Thank you, Mr. Chair. Doctor, you mentioned hepatitis C, and I've talked to a doctor that's been in the prisons. How expensive is the new treatment for hepatitis C that we're treating our prisoners for?
A course of Sovaldi is typically $90,000 for 3 months. And the cost, of course, that's seen in context if it avoids a liver transplant.
So,
And it is a time-limited course, but I don't know right now, but if it is not the single most expensive drug within correctional health care right now, it will be. I'm pretty sure about that.
so outside of prison and somebody having very, very good high-dollar health insurance, that seems to be like nobody else could afford it. Is that treatment actually putting us in a position where somebody that may have hepatitis C may need to go to prison so that we might treat their symptoms?
Now, the general guidelines, the Department of Human Services has developed guidelines for the use of Sovaldi. Generally, you have to have a certain level of liver fibrosis in order to qualify for it, and commercial insurance typically pays for it when approved, meeting those guidelines.
Okay. Senator Stubblefield, you're recognized.
Thank you, Mr. Chair. Dr. Rahm,
Yes.
is it possible that we could use a more tiered level of healthcare delivery by using our doctors who are doing their residency, who, by the way, are compensated at a much lower rate than other doctors, and using those doctors who are doing their residency and nurse practitioners? And by the way, those doctors have been taught the latest methods and the latest ideas in treating some of these people.
So we've had these conversations, in particular with Representative Ferguson and others, and we certainly believe strongly in the value of a healthcare team, and the role of physician assistants, and the role of advanced practice nurses, in partnership with physicians and others and pharmacists, in enabling a more efficient way to produce outcomes. We do not favor independent practice of physicians prior to completing residency training. There are very significant requirements for supervision during residency training. We believe that's the level of supervision that people require at that point in their training. Practice in underserved areas is more challenging than it is in more heavily populated areas, not less challenging. So the idea of using less trained individuals to meet needs in underserved areas, we don't think is the right approach. This has been discussed in a number of other states as well. We believe that residents should operate in the context of their training programs. And in fact, as a sponsor of residency programs, we would not be able to participate in something where less well-trained physicians were permitted to practice in limited fashion.
Thank you.
Representative Boyd, you recognize.
Thank you, Mr. Chair. Chancellor Ron, I don't necessarily expect you to know the answer to this right now with your mile wide, inch deep, but I want people to start thinking about it, because if we're talking about health reform, I think it's part of the issue. So do you have any idea how much you spend in order to be paid for your services? You said 75% of your revenue comes from patient care. So how many people do you have to pay to oversee this and oversee that in order to get a bill out and then get it rejected, paid back, or in terms of percentages or anything? So is there really very much waste or redundancy in there, considering you're to some level a state agency? So
The answer to that is yes. We have opportunity internally for significant process improvement, and we're working on that. So that's on us. Then there are the processes that we need to follow that require a lot of bureaucratic effort and processing. There are hundreds of individuals at UAMS employed to manage the revenue cycle related to patient care, all aspects of it. So that is a process that's frustrating for everyone involved, and certainly we, like the rest of the U.S. healthcare system, profiles as having a large amount of administrative expense embedded within the system.
thank you.
Okay, Senator Ingram, you're recognized.
Dr. Ryan, appreciate you being here today, and I appreciate hearing you say that you see the values of AHEX because they provide a lot of that service there within that hour time frame that you're talking about. Would you walk me through so that I understand, under the Affordable Care Act, dish payments that are direct payments that are going to hospitals are going away over a 3-year period? Is that correct?
Dish payments are being reduced, yes.
Okay.
I don't know the exact period.
And how much will that affect UAMS?
Well, I mean, the dish payments were there. The program is there to defray hospital-associated expenses in the care of a disproportionate share of uninsured, right? For everybody, DISH is disproportionate share hospital. That's the purpose of the program. Our uninsured rate has dropped from 13% to around 3%. As we said when Dr. Roxanne Townsend was here with me earlier. So we have many fewer uninsured individuals. So that's being supplanted by payments associated with newly insured individuals through the private option. So it's offset.
Would you differentiate for me, you've got direct dish payments that are going to each hospital, that if you qualify for it, then your hospital, you're getting a dish payment. Now, is there a separate dish payment that UAMS receives that is, instead of it being distributed federally directly to local hospitals that meet the criteria, is there another dish payment that UAMS receives that they keep 98% of that payment?
These are deals that were done in the way the disproportionate share program was set up in Arkansas years ago. We, out of our state appropriation, pay the state match. So When we receive DISH payments, we actually only get 70% of our cost. Then as a state-operated teaching hospital, there are additional programs. The physicians participate in something called an upper payment limit. There are a variety of different programs. And it was set up in a way with their rural programs. We really should have Bo Ryle or Roxanne Townsend, we really should have somebody go through this whole thing rather than I.
Okay, well then, one last question on that. The match, the federal match, I mean, the nursing homes sort of mined this area years ago of coming up with the match that we could use that the state didn't have in order to maximize the federal dollars that we could get back. Is that match money that UAMS provides that gets a return of 98% or whatever, is that 100% UAMS money, or is that money commingled with other hospitals' money to bed tax or whatever you want to call it?
You know, I'm sorry, I can't answer that question as to exactly how this is managed within DHS. We are not a conduit for other hospitals' funds. But as I said, this was not the case where I was in Georgia, but here we, out of our state appropriation, pay the match. So we structurally only in DISH payment get 70% of our allowable cost. We don't get our full cost.
Thank you very
much. But UAMS is in a different category from other hospitals, and there are rural hospitals that are in a different category. And I'm sorry, I can't explain all of that today.
Okay. Representative Hammer, you recognize.
Thank you, Mr. Chair. A couple points on the telemedicine that you mentioned a while ago. That is telemedicine as defined as being in-state, not including anything that would allow for teledocs or any company like that to be able to offer services in Arkansas. Is that correct?
Correct. What I was referring to is our system, which is built on a broadband network for which we received a $100 million grant from the Department of Commerce to build out. That's what I was talking about.
Okay. As far as position of UAMS, not favorable to the idea of teledocs operating in the state of Arkansas?
No, yeah, I mean, the licensure issues are important. Operating within the state of Arkansas, no.
Okay. As far, I'm trying to understand too, the relationship between UAMS and Children's Hospital, and as far as the billing that occurs between the two entities, is that Children's Hospital totally separate in the billing aspect from UAMS, or are they
Yes,
commingled?
Children's Hospital is a very, very important partner for us, just as the Central Arkansas VA is. We have a very tight working relationship. Our faculty who do research relevant to children are mostly based at Arkansas Children's. Our clinical faculty who provide care are at Children's, but they're our faculty. And the educational programs related to child health are based there. Arkansas Children's is a separate entity with its own board.
Okay.
And we have an affiliation agreement.
Recently, they returned $9.2 million back, or they're in the process of doing that, and I'm wondering, do you know what were the attributors that would allow them to be able to return that kind of money in today's environment? Can you speak on that any at all, and does that have any connection to what you're proposing that you can bring back to the task force as far as cost-saving measures also?
Well, you really should ask Marcy Doderer to speak to that as CEO. She's on the advisory council, and I prefer to not speak for Children's, but Children's is a well-run children's hospital. It's a great asset for the state. The decision that was made to create a single integrated children's hospital was a very important decision when it was made. Their uninsurance rate, of course, has been much lower because of our kids B and our kids A than what we've dealt with on the adult side.
A final question, Representative Hammer.
With your rates going from 13% uncompensated care down to 3%, how are the ER visits to the med center? Are they, we've heard testimony in this committee of being up or down, and so can you speak as to how that's impacted the med center and the ER visits?
Our ER visits are decreased. That's the only category of clinical activity that has decreased. Seems to me we had 2,000 or 3,000 fewer visits last year on a base of around 50,000. But again, I can give you those figures. But our ER visits were down. Our ambulatory visits were up. Our surgical cases were up. Our inpatient discharges up. Our ER visits down.
Thank you.
Representative Sullivan, you're recognized.
Dr. Rahman, I noticed on this Arkansas 49th in healthcare, when you also talked about telehealth, you indicated that, I think you used 3 FARs. We are far, far, far behind what is the national norm or what other states are doing, and you indicated there's a lot we can do. Yet we don't seem to be ready to change the way our current philosophies about access. How do we expect to improve access to care via telehealth if we're not going to change our policies?
Well, you did do, you enacted a very important change which enabled the expense to be recovered on the requesting side as well as on the consulting side in the last session. I didn't mean to say that we're far below what other states are doing. We have a tremendous upside opportunity in what we can do, and the configuration of the way Arkansas, the way we're a rural state, but there's someone everywhere, really lends itself well to telemedicine. The development of applications is also something that's ongoing now to bring distance health into the home, which is a very important step as well. So just we are working on bringing telehealth into a central role within our own vision for what our health system is and how it should work, and we believe we should do that statewide, and we believe that there are great opportunities.
Just one short follow-up, Mr. Chair. Yes, I heard you say bringing telehealth into the home. I think under the current regulation, that's illegal.
For applications, I'm unaware of that.
Okay, maybe we can discuss that later. Thank you, Mr. Chair.
Okay, and I saw the Chair of Public Health wanted to respond to that. So Senator Bledsoe, you're recognized.
Thank you, Mr. Chair. In the bill that was passed in the last session, the medical board has the authority to expand, but in telemedicine, you don't want to circumvent the authority of the medical board because that is the entity that protects the people. And so, but in that bill, the medical board and is at this moment also meeting on how we can expand telemedicine, but doing it in the right way, protecting the people, and also making sure that the quality of health care is an excellent thing that we can all be proud of. Would you not agree?
Yes.
Thank you.
Okay, Senator Sanders, you're recognized.
I'm good, thank you.
Okay. Okay, that's all we have on the list. Dr. Ron, I appreciate the presentation. You did right at an hour, which is pretty well on budget for that much information. We do appreciate your, and you know, I would encourage you to ask your folks to, this slide is the one that had the most impact on me is, as you said, there's tremendous upside, but it's not going to fix itself. So if you can bring to us solid recommendations about how we move up these, what actions we can take from a standpoint of legislative actions or state policy to move ourselves up in these, that's where the real savings are going to be. I think that's clear.
Thank you for the invitation.
Okay. Okay, members, we're going to move on now. John, if you'll come down, and he's going to speak to us about care coordination models and talk to us a little bit about what we're getting ready to hear with regard to some of the organizations that are going to present. And John, if you have any other comments or updates you want to give on what you heard yesterday, certainly take this time to use as you see fit.
Thank you, Mr. Chairman. We got a couple updates from yesterday's discussion. We were able to contact the state of Tennessee, and we have for you some updates from Tennessee directly from their director about their long-term care program. And we're going to be real quick because I know you want to hear from a lot of folks on the managed care side. But what we thought we would do first for the task force is to give you some ideas of what's going on in other states. So kind of set the stage for the discussion. I was asked by the chairs to be able to put together, look at all questions for you. We did. You accepted the questions. We sent them out to the managed care companies, and they responded. In that grid that we put together that's in front of you, you should have a grid that has across it a list of every managed care company that responded. We have, a good couple hundred pages of responses that we read and reviewed for you and condensed in a short summary, so when you hear their testimony, it may be helpful to you to look at, so you can kind of get an idea what they're doing in states, what populations they cover, what the results have been. And I think your question should be very probing in terms of the results and what they could bring and offer as value to Arkansas. And I do recognize this is all still information, and you need to make the final decisions. So I thought, Richard and I thought it would be important to identify for you some of the models that go on in other states. If you look at what we have been trying to share with you, and will be part of our recommendation, is you really have within your current model, you heard yesterday a value-based purchasing model from the nursing facility folks. What you're hearing from people is really about accepting risk, shifting the risk from the fee-for-service system into something that is more performance-based, as Representative Collins talks about, outcome-enriched, and hopefully helping enhance the quality of care in your state. The models are really, there's 3 or 4 specific models. There's a managed care risk-based model, which is a capitated PMPM like you pay to the private option, that you pay to a managed care company that basically administers all of the population health. And they have outcomes, and it all comes down to what the state really, in our opinion, decides to put into that contract. It becomes the state transforms its own department into almost a contract management focus. So you need to make sure that the department has, if you go in that direction, the best and brightest when it comes to negotiating rates, actuarial issues, and when it comes to administering the penalties or rewarding on the pay for performance in the contracts. Even writing the RFPs early on and putting the contracts together. That's so critically important. And it takes a couple years before you could even get to that point, 18 months to a year, 2 years. So you can't start that right away. But you can start preparing for that, if that's where you go. So you can look, a number of the states, 25 states have what is called a capitated full-service managed care system. Interesting, the second note here is you've got other states, 13, that do managed care, and they took their primary care case management and put it basically under their managed care operation. So they're doing managed care, and they're also doing primary care case management. And in some of the rural areas, they may have kept it to be primary care and just left the managed care operation for other parts of the state. So there's a hybrid, and you can ask some of the questions today about that model. The next model is where you are today in Arkansas, where you have your primary care case management. So it's not that you're doing nothing, you're doing a lot, and we heard about the episodes of care and payment improvement, but it's just in the primary care case management, and I would note, not in the high-cost areas. So states that have no comprehensive managed care, there are 3. That may be, currently, there may be some discussions to have managed care, and you may hear from the companies that those states have moved into some type of managed care. The ACO model is in place in 8 states, and then the DSRIP is really a model that involves hospitals being involved in a care coordination model. And if you have any questions, we can answer some of those. Care coordination and managed care. Recently, there was an AARP study that we're looking at. We thought it was really important. The AARP study looked at 18 states that have implemented managed long-term care services, capitated type delivery system that you're going to hear about today. They looked at all these states.
John,
Yes.
some of us don't know when you say capitated, what you mean.
It would be a per member per month, so it's budget certainty. We know $487 a month goes to, on the premium, to the Blue Cross, Ambetter, and also QualChoice. So the state, for budget certainty, knows they've worked out a negotiated rate, and it's going to be a certain amount, and you've got to do all these things and cover these services for that amount. And the risk is borne on you. So if seniors stay in a nursing home longer than they need, if you can't transition them, or if you end up having high ER and you go outside of that PMPM, that is your risk. You're paying for that. If you save money, there's also calculations that state of Texas, for example, is a leader in the nation in this, has been able to design a payback system so that there's only a certain amount of a profit, and then there's an experience, and they look at it, and at the end of the year, there's a settlement, and there's money that's shifted back to the state if the profits are too high. So there's all kinds of designs. Does that help? And I know I'm going fast because I want to give the managed care companies enough time to talk to you all. Then this is a really important study because it looked at the models of managed care capitated, which you're going to hear about today, and they found 3 trends in that care coordination. Even within that model, there are differences among the states in what those companies do and how they deliver the care. And I thought it's important to you to know, they have the in-house model, where an MCO provides the care coordination with their own staff, and they have primarily credentialed social workers. The next model is what's called the shared functions model, where they subcontract with existing community providers. And the community will do case management, but they'll retain aspects of care coordination. This is very important to some of the managed care companies because they like to do the care coordination because they have a lot of experience with the nurses and the folks that really do population health. The third component, and we've got another slide you can look at on the shared function model. The last one is the delegated model. And that involves the health plan delegating all care coordination activities to a health system or larger physician practice, and that the practice engages with the clients, and that's in a large area. So there are different models even within managed care, and you'll hear a lot about that today. And when you sometimes hear managed care, that term, sometimes that's a global reference to a lot of different things about coordinating the care for that population. And what I think you're going to hear today is mostly the capitated per member per month methodology, and you can ask them if they subcontract, and you can use that matrix because we've already identified for you a lot of the services that they offer. Does that help? That's just setting the stage. So the next slides are for later today, and Stephen Palmer will be back on the payment improvement update. What I want you to do now, very briefly, is to look at there was a letter that we received from Tennessee. Yesterday, we have been in discussions with Tennessee because we were interested to look at the model for you all, because Tennessee had a real problem with long-term care, very similar to Arkansas in terms of that institutional bias, very similar. Back in 2008, they passed a statute, and it was their long-term care reform statute. And we were interested to know what changes have happened in Tennessee since that 2008 statute. You heard testimony yesterday from the nursing facility folks. We know Patty Killingsbury, who's the head of the long-term care, and Richard has been doing some research to get information from them so we can make that part of your review. And we're going to be looking at other states too, so it's not just Tennessee. But because that was raised yesterday, Director Killingsbury sent an email to Richard, which I copied for all of you here. I'm just going to highlight a few things, because I think it's important. This comes right from the state, because when we're getting information, we're trying to go right to the source of the state versus a provider. And basically what is highlighted in this letter is, this is all about the Choices Program. They called it the Choices Program. So managed care capitated took over in 2008 in the long-term care area, 10, based on that 2008 statute. 2010, they started. And there have been significant changes. She said in her letter, the Choices Program was not established primarily, and I thought this was important, as a savings initiative, but rather rebalancing initiative. The intent was to invest avoided institutional costs into home and community-based care services. And then it was to look at serving more people and creating a more sustainable long-term services and support system. Significant number of persons have been and continue to be diverted, and smaller but still significant number of persons have been continued to be transitioned to more integrated community settings. Thus, nursing facility occupancy rates have continued to decline. The number of percent of persons receiving Medicaid reimbursement services in nursing facilities has continued to decline. And significant expenditures have been avoided for institutional benefits. Since the inception of the program, the state has been able to leverage avoided expenditures from nursing facility diversion transition to expand access to home and community-based services for seniors and adults with physical disabilities, nearly threefold. From enrollment of 4,861, which you're going to see on the choices slide, to 13,000 members. This yields reoccurring cost avoidance and roughly $250 million per year in institutional expenditures if the program had remained as is and the new population had received nursing facility services. So the important thing is, as is. It's just like what the state did in the private option waiver. It's what we've been talking to you about waivers. You know, when you go to CMS, you say, what if we don't change the program? Here's where you are, and here's where it's going to continue to grow. But if you make these changes, here's where you think the program can be, and it's below what it's anticipated to be. So the experience in Tennessee, from what we've gathered so far from the state, has been very positive. The final two slides, they're not on the PowerPoint, but they're with you in your copy. And if you look at the slides that Director Killingsbury sent to us, it's pretty significant in terms of the nursing facility reduction and the home and community-based increase. And a couple things that we'd like to highlight, and again, this will all be in our final report as well. But as you begin to hear from some of these companies, a few of them I think have actually been in Tennessee, so you may be able to ask them the experience, what has worked and what hasn't worked. And what we want to know, and I think the most important thing in that matrix that you have in front of you is, you know, what are the things that you don't do if you move in this direction? And what are some of the things you should focus on, quality and other areas? So anyways, I didn't want to take up a lot of time. I wanted to make sure you had that information, and we'll continue to keep digging and researching for you.
Okay, John, and members, if you look at the slide he's talking about there, the two pie charts there, I just need you to get me some more information on this if you would, because here's what I don't know. This slide does not tell us. All it's talking about is percent enrollment in the program.
Mm-hmm.
Well, that doesn't tell us what the overall cost of the program has done in dollars or in number of people. So what I would like to know is, what is the 83% reference as far as number of folks in the facilities on both the first chart and the second chart, and the dollars spent?
Yeah.
And then also the same thing for those folks in home-based health care and the cost, and then what the total cost is. Because again, and I think we also need to know what is the administration and management cost that is added to make that pie chart change like that.
And we're looking into every one of those questions.
I mean, I just want to, you know, so many times we get data that is packaged to present a particular viewpoint. I just want the entire picture. And so what would it be in dollars? What would it be in number of people? Or are we just making the pie bigger and changing the percentages of a bigger pie? That's what I need to know.
And I want you to make sure, we're going to have that in our final report for you all. But the issue of cost avoidance is not hard dollars, too. So you also need to look at where can you make reductions that are going to give you return hard dollars in terms of budget savings. So that's something we're absolutely going to review here.
Yeah, and I mean, they've got to have the data. For instance, to me, the pie chart on the right, in order to be fair, should really have a slice in there that shows MCO fees and profit or administrative costs, or whatever you want to call it. So as we're talking about dollars.
And one of the questions that you asked all the MCOs was be able to show you or explain to you in states that they've been operating, where have they been able to actually bend the curve? So that is a really important question, and you can ask that today.
Okay, we've got...
And just to make sure we get that nailed down the right way, because in a nutshell, what she seems to be saying in this letter is we're treating twice as many people as we would otherwise be treating, and we're treating them for the same money. So that's the essential answer. So my question is, if that's the case, what were we doing with that half of the people 5 years ago? In other words, is today's model nursing care for half of the people have zero expense and are just going about their merry way? In the new world, it's nursing homes for half, and now we're doing something else for a group. What happened to those new 7,000 people in the prior 5 years? That's the part that's not reflected in the numbers.
We're going to be able to get all that. We know that we've already started looking at some of those costs too. They eliminated the wait list. They used some of the funding for wait list elimination. They added a prevention program. They've done a lot of things. So we'll have all that for you in the budget numbers.
Okay, we've got 3 on the list for questions right now, and again, I just want to remind everybody, we've got 9 groups to get through here today, so again, try to make the questions quick and to the point. Representative Gray, you recognized.
Thank you, Mr. Chair. In looking at these 2 slides in reference to the question that was already asked, it shows percentage of enrollment. I also have this slide from yesterday from one of the presentations that shows TennCare choices. So in August of 2010, this goes back to the question that was asked earlier, we went from 83% enrollment in long-term care in the nursing home to April of 15 to 57%. So that's a 26% change. But we went from $900 million in nursing home spend to $950 million in nursing home spend, according to this chart. We also increased our home care up an additional $200 million, and administrative fees for the MCOs of $400 million. So I guess I'm in conflict as to what this letter says versus the total TennCare cost going from roughly $950 million to $1,550 million for total for those 3 pieces. So Senator Hendren, I completely agree. In the future, I mean, I'd like this information, but it's got to relate to dollars because these 2 things don't add up to me.
And we're going to absolutely get that information. One thing that we were going to suggest at some point too is to possibly have some of the directors who have actually run these programs even here, if that's something you'd like. But we will get all that information, and Richard had just something to add to that.
I think that's a great question. It's a question we asked ourselves last night, and we don't know the definitive answer, but I think the question we need to ask is the data that you're referring to in terms of the increase in administration fees only on the managed care contracts involving long-term care, or is it the administrative fees over the entire Medicaid program that the MCOs were given?
Okay.
Because that 10% would be $4 billion approximately, and obviously they're not spending $4 billion on long-term care.
Yeah, and even if you took out the managed care administrative fee, their costs still went up, they didn't go down. So I just wanted to make sure that this is accurate. I just want accurate information in order to make this decision.
Absolutely. It's a great question, and we totally agree with you. I think that John mentioned it before. You look for savings in a given year in terms of what you're doing, and as Dr. Ron said, if you keep doing what you're doing, you're going to keep getting where you are. I think what Tennessee did was make a decision that they didn't want to keep staying where they are because they knew the expense was going to be higher if they didn't change. But that doesn't obviate the fact for real numbers.
Thank you.
Thank you.
Okay. Go ahead. You have another comment, John?
All set.
Okay, Representative Ferguson, you recognize.
Thank you, Mr. Chair. Of course, I come to the managed care with a certain bias because I lived through the 90s and the HMOs and all of those issues. It's been my philosophy that if we could do care, all managed care companies bring is care management, really, and care coordination. And I guess it's been my feeling that if we could do those things ourselves, that the administrative costs would be less if we do it through DHS. But one thing that's not addressed in this chart that you gave us that I would like you to address is the legal issues that other states have had and the problems that they've had with managed care. I know Kentucky's had serious lawsuits, Kansas, and now Florida has had the lawsuit with their managed care company for not delivering what the contract said. And then once you've gone with managed care, you've dismantled all your administrative capability, and you're kind of in a rock and a hard place. You have no place to go. So address those this talks about where they are, but what problems other states have had and why we should go to managed care, or what we should do contractually to avoid those kind of problems if we do go to managed care.
Representative Ferguson, that's a great question. I think that should be asked to the companies today because I want to take notes and listen. One of the things in the 24 questions, you can only ask so many questions, and I want to give them at least thanks for addressing the 24 questions the way they did. And you know, it was an average 45 to 50-page response, which we'll provide to all of you. And one of the questions that I left out for you was liability. And I'm so glad you mentioned that. So I'd be really interested to hear the answers. I don't have specific information for you on that.
Okay. Senator Sanders, you're recognized.
John, I think, given Dr. Ron's testimony and some of the questions from the committee members about upper payment limits and dish payments, and I know with respect to hospital assessments and the provider tax, it would be very helpful, and I know we have some of this sort of spread out through the reports, but I think it would be very helpful to members if we could get on a one-pager some sort of assessment of sort of the financial models. And I look back, back at a couple slides ago, you had sort of the examples of MCO models and the disparate model in New York and Texas. And also maybe sort of a primer on the additional spending authorities that those other states have. For instance, both Texas and Florida are currently they're not a Medicaid expansion state, but they're currently receiving money that Arkansas never had to cover uninsured. So, when they're all out there beating their chest and talking about how awesome they are, they're actually getting money from the federal government.
Yep.
And when the federal government said, hey, we're going to look at pulling that back, we're not getting any of it. They've threatened a lawsuit against the Fed. So I think sort of rounding out, obviously there's the policies and sort of there's people, process, and tools, but I think the funding mechanisms that these other states have, because we've all said it, you've seen one Medicaid program, you've seen one Medicaid program, but showing that in just an easily digestible way, I think will help, because if we were to move to a disparate model, I think there are only a couple small places where that would work here. So I think it would sort of inform, as we begin and continue our deliberations, I think that would inform us a lot.
We're already working on that for you.
Thank you very much.
Okay, members, that's all we have on the list. We're going to go ahead and come to the first group. And let me just say to the folks who are here, again, I want to thank you all for coming. And I will tell you that we've had now up to 3 requests of changes versus schedule. And so it's really just become not possible because we change one, it ripples, and then someone else is going to miss a flight. So we're going to do the best we can to keep it expeditious, but we're going to go with the order that's here on the sheet. And again, this was just as the order as the information was received. And so the first group to present is AmeriGroup. So if the folks from AmeriGroup will come down. And again, members, let me remind you, if you're getting the presentation that they're going to use today, and you also have the grid that John talked about earlier with the answers and their responses there. And John, if you would, the information that you got as far as the responses, send that to staff so that any of the members that want to read through that'd be some good information for folks to look at. Okay, if you'll identify yourself and who you're with for the record, you're recognized to present.
Thank you, Mr. Chairman. My name is Michael Scarborough. I'm with AmeriGroup Corporation, and pleased to present to you today about our organization. Look forward to your questions, and certainly do not envy the challenge you have before you. It's a very challenging issue for the state. We recognize that, and certainly have been proud to work through a number of states as they've looked at this type of transition and worked with them successfully through it. So I'm going to try to move through my presentation quickly. I know you guys have a lot of presentations today. I don't want to bore you with PowerPoints, but I will just move through just some quick facts about our organization. And if the chair will allow, I'd like to spend just a little bit of time attempting to answer some of the Tennessee-specific questions, because we have some information that I think would be helpful to some of the questions that you and Representative Gray asked. So I'll start on slide 2, and hold on here. I'm sorry, I didn't get my... So our value proposition, we believe in Medicaid, is simple. We help states manage cost, both administrative and medical cost, improve clinical outcomes, we provide a satisfying customer experience, and we help states in the provision of thought leadership, helping them think through the kind of program changes they need to make to be successful to reach their goals in each individual state. Our experience is wide. We have 24 years serving Medicaid populations across the United States. We serve 5.7 million Medicaid members across 19 states.
Okay, If I want to interrupt here just for a minute, because I think we're going to have potential for some confusion here just a minute. So Phil, where did this handout come from? Phil.
It came from us, sir.
This came from you guys?
Yes, sir. I'm going to talk about this at the end, if you don't mind, or I can talk about whatever you'd like.
Okay, I didn't know. I just wanted to know because I was thinking we were back on the other issue. So this is part of your presentation?
Yes, sir.
Okay, I'm sorry. Go ahead.
Okay. So we serve 5.7 million members in 19 states. And, related to the request for information that was released by the state a few weeks ago, we serve a significant number of members who are in the populations that you are evaluating. So we provide fully integrated physical and behavioral health care services for 5 million of our 5.7 million members. We serve over 882,000 members who are in the age, blind, and disabled category, for which most members who receive long-term services and supports are a part of that category. And actually in 8 states, we provide a fully integrated behavioral, physical, and LTSS model for over 270,000 age, blind, and disabled members. As for the benefits of what we offer, I'll start with members, the actual recipients of Medicaid services. I'll start with just coordination is the key of everything that we do. Really coordinating our members' needs, helping them to get the services that they need when they need it. We're certainly focused on the physical health care needs, but also the behavioral health care needs, as well as the social support needs of our members. We recognize in Medicaid, if you're not addressing all 3 of those issues, you will simply not be successful in helping the member achieve their goals, nor the state and theirs. The second element is we help members improve access to care and get the services that they need. You alluded to Kansas earlier. When the CanCare program was implemented, we've actually helped CanCare achieve a 23% increase in the use of primary care services in their population. We've also improved the access to home and community-based services. Within the first year of the CanCare program, we've seen a 22% increase in the usage of home and community-based services. And in Tennessee, a 100% increase within the first 3 years of the program. But also, as it relates to our members, we're accountable. We improve health outcomes, we improve quality of life. Within the first year of our program, again, in Kansas, our employment specialist helped over 70 individuals with a disability gain meaningful employment. And then in a 2015 study within Texas showed that their STAR Plus program, which is their program that would be similar to the program that was contemplated within the RFI released by the state of Arkansas a few weeks back. Their STAR Plus program has achieved significant improved outcomes, reduced complications in diabetes, decrease in bacterial pneumonia, and just a significant number of improvements in the physical health of that population. Our benefits to providers is one of the things that we talked about earlier is the movement to value-based purchasing. Over 60% of our 5.7 million members are covered by a value-based purchasing agreement with their provider. And so those programs have been successful beginning to move from a fee-for-service system to a payment-for-value system. And in the early years of this program, we've already seen a 3% improvement in quality scores by primary care physicians participating in that program, and an 8.6% decrease in the medical cost for providers participating in that program. We're a strong proponent of the patient-centered medical home model that you heard talked about earlier. We have been a large supporter of that from the beginning. We help literally hundreds of provider practices become certified as a patient-centered medical home, support them with tools and information to help them be successful, because we recognize the more successful that they are, the more successful our members will be in getting the care that they need and ultimately delivering on our value proposition to the state, which is to reduce the total cost of care or at least bend the cost trend. And then our benefits to the state, we have a highly local operating model. We are not operators from afar. We build very strong infrastructure in every one of our 19 states that we're in today. We have local health plan leadership, local clinicians, local provider relations and provider network individuals who work within the delivery system and within the needs of each state customer. We deliver savings. There is currently a study that was released just recently on the state of Texas managed care program that showed that state achieved $3.8 billion in savings from the use of managed care. And the state of Kansas, these are their numbers, not ours. The state of Kansas is estimating upwards of $1 billion in savings within the first 5 years of the implementation of the KanCare managed care program. And we're a solution-focused partner. We worked with the state of Tennessee in the implementation of the Choices program. We helped them think through some of the design elements, and we certainly worked with them on the implementation of that program in 2010. And within that program, we have a typo here on the presentation, we actually helped the state of Tennessee move from 50th in the nation in their state fiscal year 2009 in the use of home and community-based services to now 23rd in the nation in state fiscal year 13 instead of 26th in the presentation. And then we're working with states like Kansas and Tennessee to help them design improved delivery care models for their intellectual and developmentally disabled population. And so with that, I would like to, if you would allow, to talk about the information that was shared yesterday, it was alluded to earlier, as well as the chart that you have in front of you. So I'll start with the chart that you have here. I apologize for the poor quality of it. This came from Patty Killingsworth from the state of Tennessee. She took a picture of a slide that she had at 5:50 this morning and sent it to me, and so we were able to make some copies for you. So I want to contrast this slide to this one and just try to help you understand the differences between the two pictures. So Patty's slide from the state of Tennessee shows an apples-to-apples constant view of the expenditures for long-term services and supports. So this is just for the long-term services expenditures for nursing facility and home and community-based supports from state fiscal year 08 through fiscal year 14 projection. And you can see the cost line there is relatively flat. The difference between that information and what was presented yesterday is that the red bar showing the managed care cost are not simply administrative expenses, to your question, Representative Gray. This is a comprehensive program that includes long-term services and supports, physical health care services, and behavioral health care services. That red line represents nearly $1,000 PMPM. I can assure you that is not the expenditure on administrative expenses. That is all of the physical health care and behavioral health care services in addition to the green and blue lines. So this is an all-in cost. What this graph did not show is the medical and behavioral health care costs that were incurred for Choices members before this program was created.
Does this chart that you present here with the dollars include any overhead, MCO fees, administrative fees?
It does not. Those are all in this red line.
So, I mean, I guess what we've got is we've got charts of two extremes here. One piles everything onto one segment of it, and one puts nothing in it. And I guess what I would like to know is surely there's a way to prorate what percentage of those administrative fees and MCO fees are appropriate to go into this chart so we can get a true cost representation about what's going on.
Absolutely.
We've got three on the list here, so Representative, make sure you're recognized.
Thank you, Mr. Chair. My question is on the last slide here. It says the provider enrolled in a value-based reimbursement arrangement. Could you, I know you could probably spend an hour or two on it, but if you could just briefly just summarize what value-based reimbursement arrangement means.
Sure, that's a great question. Thank you, Representative. Basically, a value-based reimbursement arrangement for us is basically moving physicians, hospitals, and other providers in the delivery system away from a simply fee-for-service approach. You render a service, you get a payment, and that's the end. What we have done is begun to move providers towards value-based reimbursement, which looks at the outcomes of that care. And based on the outcomes of that care, rewarding you for positive outcomes. So in essence, it allows providers to be rewarded for the value they create. So often in the fee-for-service system, the challenge for a provider is simply, if I do all this extra work and it generates savings, I don't get any of that. I get paid for only the services I deliver, and so if I deliver value and I deliver less services as a result of that value, that just doesn't work. That's not a very good economic proposition. Our proposition is to change that and say, no, there is an opportunity for you, and it's to be rewarded to share in the savings that are created. And so that's what these models are, is to create, in essence, a shared savings approach with those practitioners that are helping to create the value to begin with.
Okay. Thank you, Mr. Chair.
Senator Ingram, you're recognized.
I noticed with particular interest, one of the challenges we have is physician care in Arkansas. And one of your bullet points talks about you improved access to preventive, primary, and specialty care in Kansas under KanCare. Would you maybe expand on that, how you did that?
Sure. Thank you, Senator. I would say in part, not only have we done that in Kansas, but we've done it in other states. I think part of it is working to know the delivery system, to know the providers that are best capable and most ready to treat Medicaid members, and helping them honestly create value propositions to treat additional membership. And so what is so often the challenge in a fee-for-service system is simply the economics of seeing additional Medicaid members are not favorable for their practice or for their hospital or for whatever type of provider they might be. And so for us, because we take risk for the services delivered and the risk for the outcomes, is to look at opportunities to create value, back to the prior question, and reward providers for additional access, additional points of access, whether that be expanded hours in the evening, and then basically paying providers additionally to stay open those additional hours, because it is far more cost effective to do that than it is for that patient's only option to be going to an emergency room. And so, instead of incurring a $400 or $500 or more ER bill for what is routine care, I can offer that money and maybe an enhanced reimbursement to a primary care physician's office to expand their hours.
Can I ask a question? I'm just going to call this the elephant in the room question. So if we're smarter than you, why can't we just do what you do and save whatever money we'd have to pay you? What is it you can do that I'm too dumb to do, or refuse to do, or won't do, or why is it you can do it now to pay you money and not just do it myself?
Representative Collins, I wouldn't say any of you are too dumb to do it.
You didn't. I just said I was personally, and no one else.
Here's what I would offer. I think the value proposition that we bring, and I would say the people coming behind me would probably say something similar to you, is we help states manage their programs better than they are able to do it alone. I think the opportunity, the experience that we bring from multiple states and understanding how these programs work, understanding these populations, certainly a state could do it, but when you're placed at full risk for the outcome of that service, we will lose money if we are not effective at managing these services. If we don't improve the quality of services, the members' health will get worse and cost will go up, and we will lose money, quite simply. So it is a profit motive.
In other words, if you don't quit smoking, you know you're going to get lung cancer.
Yes, sir.
Representative Hammer, you recognize.
Thank you, Mr. Chair. One thing I need a little help getting my mind around. You mentioned that y'all support the medical home model, and this is, did I hear you right when you said that? Okay. And so it seems to me that under the medical home model, it's the physicians and that office's responsibility to get the best outcome of care for those patients that are seeing them, correct?
It is, but we assist them in that. We support them. So we're not just saying good luck, tell us how that goes. We actually help them with information, with tools, even with support staff and enhanced funding.
Okay, then will that reduce the amount of money that's returned to that medical home because now you are doing what they should have been done in the first place, or will they continue to be able to receive that money that they currently are now? And that's what I'm trying to get my mind around. Why are we bringing in another layer if it's already supposed to be being done now, and who's going to cover the cost of that, to Representative Collins' question?
Representative, I would just say our performance speaks for itself. I think we have a track record of doing this successfully with practices all across the country in rural settings and urban settings and all different settings serving Medicaid members. And what we're able to do is help physicians be more successful in the delivery of care and do it in a more efficient and effective manner. And I would say that would at least be the value proposition of why you would hire a company like us.
Then why would physicians, because one thing I'm hearing, out of the trenches is that there's a fear by the providers of managed care coming into the state. Would you address what that fear factor is from y'all's side, or what you understand? Just talk about that for a minute.
I can't speak for the physicians of Arkansas and what their concerns might be, but I could certainly understand it's probably fear of the unknown, fear of reimbursements being cut, services being slashed, et cetera. And I would say what we do is quite the opposite. We recognize that the right services delivered at the right time are what makes programs like this successful. And because the state pays us a fixed amount, we have an incredible incentive to make sure that that happens successfully, because if not, we're on the hook for it.
Okay, final question.
What happens, you talked about risk a while ago, when you step in and say we went with a managed care approach and you assume the risk, is that just, you only spoke to the financial side? What about the risk that in the event that somebody, doesn't get the number of visits that they need for a particular issue, and it has an adverse effect on their health outcome, and they have to live with that the rest of their life? How is that risk mitigated then?
It's a great question. One of the things that many of our states have done, and I would encourage you as a committee to evaluate this, is placing a percentage. If you go the managed care route, consider placing a percentage of the amount you pay to managed care companies at risk for quality outcomes. And we have seen states do a variable percentage of the premium that puts a certain amount out there as an amount to go get to improve the measurable quality of the population's outcomes. And that helps to keep your managed care companies focused on just those kind of issues.
Okay, members, we've got 6 on the list right now, so we're going to start asking you to do one question and a follow-up, and that's it, so that we are fair to the people who present later in the day and save them sufficient time. So, Senator Ingram, you're recognized. Representative Gray, you're recognized.
Thank you, Mr. Chair. I guess one of the questions I have, I found a news article, it's on WFSU.org. It was from July 31st of this year, in which they were talking about Florida, and, as one of they have managed care throughout the state. Right now, they're reported like $500 million to be in the red. As of December of 2014, they had this is the managed care companies had a $300 million loss, and they've come back to the state and asked for a 12% increase in what their fees are going to be. We don't want any surprises down the road. Can you explain to me how this model was introduced as cost savings? Now the state of Florida is saying if they agree to this, they actually negate all cost savings that were promised to them. It's going to cost them more than where they originally were. Can you explain that to us?
I'm not equipped to go deep on the Florida issues. I'm not as familiar with all of the issues there. I will say it is incredibly important that as a state, if you're going to go with managed care, that you hire an absolutely highly qualified actuarial firm that will help you price the business accordingly, to help you set the premium rates at what's referred to as an actuarially sound level. The state of Florida has a program that was going through significant changes through that premium setting process. And I will just say that in general is problematic, even for an actuary to do correctly, to set rates correctly up front. And in the case of Florida, it looks like the rates were not set correctly. And so my recommendation for you would be to not make changes on top of changes on top of changes, because it gets very hard for you, for your actuary, and even for the MCO to actually understand well what the real cost of services are.
Okay, thank you. And just my follow-up question is, has your company in particular, you do business in Florida, has your company in particular gone to the state and asked for an increase?
We are talking to the state about an increase in rates for the next fiscal year because of the performance we've seen since our performance before the addition of the additional populations was adequate, and since the introduction of new populations, our performance has degraded.
Okay, thank you.
Okay, Senator Cooper, you're recognized.
Thank you, Mr. Chair. Moving 70 people with disability to transition to employment, that sounds like a pretty small number. What's the significance of adding that in the big picture?
I would say in the big picture it may seem insignificant, but for those 70 individuals, it was certainly a significant event. When you're talking about a population of only a couple of thousand who were eligible for this service, moving 70 people was significant, considering we're only 1/3 of the Kansas population. 2 of my competitors in Kansas will speak later. They may have similar numbers that they could share. And so I would say if you take the 3 organizations, if you take just my experience, multiply it by 3, 200 individuals with an intellectual or developmental disability were not meaningfully employed before our employment specialist worked with vocational rehabilitation in the state of Kansas and helped identify members who wanted to work, were capable of working, and needed just the supports they needed to be successful in the workplace. And so, you know, I think in this business, it's the nickels and dimes that move things. And so what appear to be small numbers in the big scheme of things, I think are actually quite important.
So are you saying that that was included to indicate something larger than beyond the 70?
I think that's just the first year. You know, I think the opportunity is, it demonstrated success. It shows a value to the state. We're seeing a return on that investment, and so we're going to make more investments like that in states like Arkansas that consider those kind of populations moved in.
Okay, thank you, Mr. Chair.
Representative Flowers, you're recognized.
Thank you. I guess I would sort of count myself with Representative Collins and try to make this really simple for me. I asked you to try to make it simple for me, and I think I have a very broad-based question, but it'll give me some perspective about your 24 years experience and then your ultimate success in being able to exercise the value that's outlined right here. And that said, in the 24 years of helping states manage these costs as well as improve clinical outcomes, would you be able to identify any of those states or any of your clients over time, whether short or long term, having been able to either maintain or decrease healthcare costs and improve clinical outcomes in a measurable way? And I say that having just heard from Chancellor Ron, and he presented information about our disease states' mortality and morbidity that places us at number 48.
Thank you for your question. You know, I would say I'll start on the financial front, and then we'll talk about the outcomes front. On the financial front, in the information that was submitted in request to your questions, we talk about across our states, our medical cost trends are 1 to 4%. Across our states over a number of years. So I think we have been successful in most of our states in being successful in bending the cost curve and bringing Medicaid cost in control. You know, I would say if you were to ask our state customers, and I'll just give you an example, this past Monday we were successfully awarded an opportunity to serve the state of Iowa's Medicaid program. As you may know, the state of Iowa had been last year going through the exact same issues that you're dealing with here today. They're going to a full risk managed care program that's anticipated to save $53 million in state funds in its first year. And if you were to look at our response to that, we were required within the RFP, the request for proposals from the state, to submit references from our state customers. And our state customers, speaking on their own accord, filling out a document from the state of Iowa, rated us as exemplary in all areas of performance, including helping them manage cost. And so I'll let my customers speak for themselves, and I would encourage you to speak to your peers. Speak to your peer states, speak to their legislative body, speak to their administrators, because I think they can answer those questions far better than I can, because you might have some suspect about my credibility on the issue, but I certainly think they can speak well for themselves. On the outcome side, our organization is rated as number 1 or number 2 in state quality rankings in over 2/3 of our states. And so we take quality of care seriously. We're very focused on improving the outcomes of that care. And, you know, as far as moving mortality statistics, as far as improving overall health care in the communities that we serve, I think the results from the states that have put us under various quality programs and incentives and penalties for failure to provide high-quality services, we have received very high rankings from the vast majority of our states.
Okay, you have a follow-up? And let me just ask you to do the same thing. Keep your answer short, because we've got to get 8 more groups going through here. What's your follow-up?
Yes, thank you. I guess my next follow-up would be, in terms of how you all operate, who are the decision makers in terms of the medical procedures? What is the role of physicians versus someone who is not a physician or not a health professional?
Well, I can assure you it's not people like me. So there are physicians involved, physicians and other clinical professionals who are involved in helping to make any of those kind of coverage decisions. So we have a chief medical officer in every one of our states, and normally a number of medical directors and other clinicians around them to help support making all of those decisions.
Okay, Representative Meeks.
Thank you, Mr. Chair. My question is this too. I love competition and I appreciate you wanting to do this, but I do know that Anthem, or at least they used to be, is with Blue Cross and Blue Shield. And so my question is, we already have Blue Cross and Blue Shield here in Arkansas. Can you explain how you would fit in, you know, if you guys were to come in, would that hurt Blue Cross and Blue Shield here in Arkansas? So could you kind of go over that aspect of it, since you're both Blue Cross and Blue Shield?
Yeah, let me briefly explain. So Anthem is the licensee of the Blue Cross and Blue Shield brand in 14 other states than Arkansas. And so our Blue Cross Blue Shield of Arkansas is a co-licensee of the Blue Cross and Blue Shield brand. They just happen to own that franchise right for the state of Arkansas. You know, I would say in the name of competition, we're here to certainly compete for a chance to win some of this business, but work alongside organizations like that for the most successful outcome we can have for the state. I mean, ultimately, in this business, it requires having good, strong competition who can provide the level of services to our state customers for these programs to be successful. And so we have every incentive to work together on the kind of programming we can create to help states be successful together.
Follow up, Mr. Chair. So, in other words, if you were to get the contract and we were to go in this direction, and you were to get the contract, how would you fit in with Blue Cross and Blue Shield? Would you use them? Would you not use them? How would that? How does that normally work? Maybe in other states where you have the same thing going on.
It varies by the relationship. Sometimes we partner with Blue Cross and Blue Shield plans. We actually help a couple of Blue Cross and Blue Shield plans operate their Medicaid programs in other states. So I would say that's a discussion between us and Blue Cross Blue Shield of Arkansas. Should they be a competitor or a cooperator?
Okay, thank you, Mr. Chair.
Representative Boyd, you're recognized.
Thank you, Mr. Chair. This is just a quick question. On slide 5, it says that there were 3.8 billion savings in Texas from 2010 to 2015. I'm just curious, is that savings before you paid for the managed care fee or exclusive of the managed care fee?
It includes all of the cost of the program, including all of the service delivery as well as the administrative expenses paid to the managed care organizations. And the report that we cite is within the response to your questionnaire sent to us. So that is not our numbers, that's the state's own study conducted by an independent firm.
Okay, that's all we have on the list. Mr. Scarborough, I appreciate you. Sometimes the guy first gets all the hard questions, so you handled it well, and I appreciate you coming down and your diligence in these and provide the information. So I'm sure we'll be in contact as we move forward. Okay, next we're going to hear from Centene, so the folks from Centene will come on down. We're handing out their presentation now that they're going to walk us through. So I believe we have John Ryan and Lisa McClellan. If I'm wrong, tell me, but state your names for the record and you're recognized.
Thank you.
You are not wrong. Lisa McClellan with Centene Corporation.
John Ryan, Centene Corporation. Thank you, Mr. Chair and members of the task force. Do you have our presentation electronically up so you can see, or? We've got it right here. Okay. I'm going to move through this presentation deck pretty quickly, Senator, so we can get to some questions and be respectful of everybody's time. So if you'll turn to the first, actually the second slide, tell you a little bit about our organization, Centene Corporation, based out of St. Louis. We do business in 23 states, with 23 state customers providing a full range of managed care Medicaid services, as well as Medicare products and health insurance marketplace products. We work with about 240,000 physicians nationwide and around 2,300 hospitals, and we serve, have the privilege of serving about 4.6 million managed Medicaid and Medicare lives through that population. The next slide will tell you just a little bit about, I want to spend a little bit of time on our philosophy. We have much like you heard earlier, we do have a very localized approach with what we do in the states that we enter. We firmly believe on anything that touches a member, a provider, or our state partner, we have a local footprint for. So we do place jobs in the actual local community. There'll be care coordinators, provider relations representatives, member service representatives, and a full management team in place in the local market. We'll talk a little bit about this as we do business in Arkansas with the Medicaid expansion private option here in the state, and we do have an office here just down by the river at the old Altel campus, so I will talk a little bit about that later. So the other big philosophy that I want to talk about and that you've heard some about is care coordination. We firmly believe that the real opportunity within the most vulnerable populations in the state is the opportunity to organize the care of the individuals and ensure that they receive the proper care in the proper setting. We're not interested in rationing care or limiting care. We're interested in appropriate care. We're interested in working with local providers, with families, with caregivers, with community organizations to help coordinate the best care available. That's in urban settings or rural settings. Healthcare compliance is very important for us to work with our stakeholders on making sure that we're compliant. We have a full-fledged reporting capabilities so that we can monitor the state, or the state can monitor us in an oversight capacity, so that we feel like that's very important. And then cultural sensitivity. We do feel like, since we do operate in this population, in this setting, in multiple states, 23 states, that we do have an excellent line of sight on what it's like to work with Medicaid populations. Again, geographically, you can look at where our footprint is nationally, heavy concentration in the southeast, working with states like Mississippi and Louisiana and Texas and Missouri that all border our state. Locally, who we are, we work in full statewide operation, 6,000 hospitals, 6,000 physicians, 70 acute care hospitals, 170 employees, and that's growing rapidly every single month here in the state. We've been in the state through various organizations for the past 17 years, have a very fine understanding of the statewide provider community and the member community, as well as working with state government, Arkansas Medicaid Agency here in the state. One of the questions we received was to talk about the experience of that we have with various populations and aid categories within the Medicaid space. And as you'll see here, this grid is very helpful. You can see which population and aid categories we work with in each state. But I would call to your attention that we work with virtually every aid category that's available within the Arkansas Medicaid program and are fully equipped to continue that. One of the benefits of working with our organization is we have a full integration of specialty companies. So what that basically means is that those benefits that are very important to the beneficiaries that we serve seek services for dental care, for vision, PBM services, behavioral health, life and health management. Those specialty services are actually integrated into our own company through companies that we do own, that we work with on a regular basis. So there's a full integration of serving the whole individual. I won't spend any time on this integration, but this is just to say that using our own, one of the questions we were asked was about if we have our own MMIS system. In fact, we do. We own our own proprietary system that we manage over 4.5 million lives on. Completely scalable, but it does allow us to aggregate information from all of our providers, all of our members, all of our specialty companies into one set of integrated reporting so that we can address cost-saving opportunities and quality improvements for our membership in an integrated fashion. Accreditations, I think it's very important, as we talked a little bit about here, to ensure good quality outcomes. All of our health plans either have or are in the process of obtaining full accreditation with NCQA. to ensure that quality standards are in place, and so that we're not just chasing dollar savings, we're also chasing high-quality outcomes for members and patients. We did mention in our response times that we do work with various models of primary care medical homes throughout the country. In point of fact, we are working currently with the Arkansas Primary Care Medical Home policy with the private option membership that we have in the state. We enjoy that relationship. We're highly supportive of the PCMH model, and we think it can ultimately continue and succeed in a care coordinated model within a managed care, Medicaid managed care environment. Again, the key that we do want to stress is that when the state is looking for looking at a Medicaid managed care model, is that you really do look and take a deep dive into the care coordination models. What do they all entail? Do you have boots on the ground in the marketplace? Are they in the communities in Arkansas where the patients are? Is there a high degree of coordination with local providers, local caregivers, and local support systems, even outside of the provider community? Those care management teams are going to be integral to the way in which the managed care Medicaid savings can be realized and better outcomes can be placed for the state and for the member ultimately. So it's going to be extremely important that those care management teams are in place and they're functioning at a high degree within the care coordination model. And then lastly, I want to spend just a second talking a little bit about some of the innovative models that we have in place today in some of the states that we work in. Connections Plus is basically a 24-hour opportunity for members to connect with representatives of our company to help direct them to the appropriate care setting, to help direct them and advise them on how they work with their providers in a collaborative fashion in order to receive the appropriate care in the appropriate setting. So next we have a Cent account program that we use, which is basically an incentive program for healthy behaviors. That's very popular with our membership for obtaining a flu shot or having a wellness visit or some other type of healthy behavior, rewarding those members and those individuals for that healthy behavior. And then Start Smart for Your Baby. We all know that the Medicaid population is highly focused on or has a high degree of pregnancies around the state. And I think it's very important that in recognition, depending on the aid category that's ultimately considered, it's very important to address all aspects of those populations. And one of the places that we've seen the biggest opportunity for care coordination and real increase in outcomes is with the OB population, and that is ensuring that we have a high degree of coordination between those members and their physicians in order to alleviate the high-risk need that might be there and address those populations so that we can have better outcomes and avoid unnecessary stays. So with that, I'll yield to the question.
Thank you very much. This morning, Dr. Ron gave a presentation, and he put up a chart, and it said Arkansas is 49th in health, and he listed 15 of the 27 measures that are used by Annie E. Casey Foundation and America's Health Rankings 2014. And then he said he'd like to see our goal to be #1 in the SEC. And I'm going to guess that would be from moving from 49th to 32nd. So if I wrote you a contract that said, I don't want to spend any more money on Medicaid, and gave you the whole kit and caboodle, everything, the whole $5 billion, every population, however it's properly said, and said the deal is you have to keep our spending at $5 billion, and 5 years from now, we'd come back and Annie E. Casey and whoever this is would say Arkansas is 32. Would you sign a deal like that?
Well, since it's an SEC question, yes, absolutely, Representative Collins, I would. We're not known to shy away from competition in the SEC or at Centene, so I would. But I would also tell you that, as Dr. Ron mentioned, that's a whole behavioral population health shift for the entire state. That can't be achieved with one angle, as I think he said as well. I think that managed care Medicaid is an excellent way to help contribute to that and to be a driver and a leader in that effort, but that's a whole transformation of the whole health economy of the state. That's incumbent upon stakeholders at the state level, at the local and county level, at the provider level, at the managed care level and the state agency level. So I'd welcome the opportunity to do that, but I wouldn't say that that's incumbent on any one constituency at all.
Okay, John, I see in your grid there that you're involved in Medicaid expansion in several different states, including Arkansas.
Right.
Do you have any states that you're involved in that have done a managed care fee-for-service type of approach for Medicaid expansion?
Not off the top of my head, Senator.
And the reason I ask that is, I don't know if you heard yesterday for the governor's presentation, and he made the asked us to consider the possibility of allowing some of those people would be in a private insurance market and some would stay in traditional Medicaid expansion. I guess I would ask you, based on your experience, how is the cost of a managed fee for expansion type of approach compared to what you've seen in Arkansas with private option insurance policies?
Yeah, I think that the expansion populations that we're involved in states outside of Arkansas are in the managed care framework already. So they're not in a straight fee-for-service environment. So that comparative might be, I don't know that I would have the answer to that for you. I would say that the Arkansas experience, because we are really new, and we've had these individuals for just have basically a year's worth of experience, I think there's some normalizing within that population that has to happen. So where we might have reported and seen spikes in certain things like ER utilization, I think that's a transitionary phase that will continue to normalize out. But I wouldn't have a comparative on fee-for-service in managed care expansion states outside of Arkansas.
And obviously, I guess this is for our consultants over. That's something that we're going to certainly have to have some information on and what the impact might be on the insurance market if that number is reduced through some sort of scale. The other question I would have for you, and I noticed in your things to avoid answer, and many of the other companies have said that, made the same comment, but you say avoid carve-outs of specific services. And I guess my question about that is, for instance, in the state of Arkansas, where we've seen the physicians work hard for management of their own practices and episodes of care, why would it be necessary for a state to say you get it all versus, okay, it makes sense to manage this particular segment or this particular segment?
Yeah, so I think when we're saying carve-outs, first and foremost, what we mean is carve out of a particular benefit. So don't carve out pharmacy, don't carve out behavioral health, and that's because when we're looking at a person, it's a whole person. And so they all impact each other. Someone with a behavioral health condition is going to have an impact on their medical well-being. And so for us to really do that holistic, big picture, make the best impact, it's having access to all the services and all the data.
Is that what most states do in their approach, is give whole person type of approach, or do they offer contracts for certain segments?
Most states are moving more and more toward whole benefits, even including now the long-term care, which has historically been slower to evolve into managed care, but certainly medical, behavioral, pharmacy, vision, dental. That's not all, but most, yeah.
Okay. Representative Hammer, you recognized.
Thank you, Mr. Chair. As a private business, what do you do, and what's your experience when you're in a state where you run into legislative roadblocks that maybe the law prohibits certain things from being used, that you as a company really feel that to achieve the success you've got to achieve, you need this, but what's your history of resolving those roadblocks in cases like that?
Yeah, that's a great question, Representative Hammer. I would tell you and give you the example of what we experienced in Mississippi. Mississippi actually had a law in the books that said no managed care Medicaid at all, period. So we worked with the stakeholder, with the governor's office and with the legislature there to educate the membership and actually flip that around to where there was an offering for managed care Medicaid. So it's incumbent upon us to educate you and answer your questions so that you have a full understanding of what the objectives and the goals are, and we can work collaboratively in developing legislation that works.
And then secondly, we've heard mention of the medical home model. You actually referenced it in your comments. Under the medical home model, reimbursement rates are based upon successful outcomes for patient care. What's not working in our present system and our present model that necessitates us bringing in managed care in order to get us to where we ought to be based on our the 49% ranking that we hold now?
I think there's greater opportunities to incentivize and reward physicians for, as Dr. Ron commented this morning, on looking at the entire population versus specific patients. So I think there are good chances for things like diabetic management, asthma management, ensuring that A1C levels are appropriate within a population of a physician's office. I think incentives and rewards for that are highly valuable for both the member, the state, and the provider. So I think expounding upon the incentive bases that we have today is a good idea. I think working collaboratively with those provider groups to find out the best solution for value-based payment for them might be different in Heber Springs than it is in Dermont, just to be frank with you. So I think there's a good opportunity to work with providers to increase those and make sure that we hit real quality outcomes. I mean, that's what we're driving at. I mean, we've talked a lot about cost savings, but Dr. Ron was spot on this morning. We've got to walk that hand in hand with quality outcomes, and the best way to do that is to reward for performance.
Thank you. Senator Ervin, you recognized.
Thank you, and you've already touched on some of what I was going to ask, but mainly on providers and what's required of providers. And I'm looking at this slide right here with your data warehouse, and you've got all the different things coming into that. What would then, if you came in, would be additional work for your providers to be included? And I'm constantly looking at, the paperwork and there's so many things that happen inside of a real-time situation, and what extra burdens would be put on providers to be able to be compliant as part of the network.
Yeah. Go ahead.
Yeah, so Senator Ervin, I think that I wouldn't phrase it as burden necessarily. I understand what you're getting at. These are going to be things that when you structure a managed Medicare arrangement that you work with the state with to establish. Some of the ideas and the notions and the concepts that are used today in managed care that we have in place today are going to be very familiar to providers. We try to make that as easy as possible with online tools so that there's not a lot of paperwork back and forth and faxing and et cetera. We also try to work with individual providers that might have unique needs, or they might be in a unique situation or with a unique set of populations to kind of custom make and tailor made any kind of requirements that we might have if there's a unique situation. So I think it's really working with the stakeholders involved to see what the actual needs are and see what the actual program is going to look like. I would tell you that the provider functionality is going to differ between the long-term care population and a TANF or a CHIP population. So they're going to be unique to those particular populations.
And your presentation is really more focused on management. And I think that's an interesting, it's different because you're more focused on care management versus, the financial and the reimbursements and all that type of thing. So do you feel like that is really where you find the more bang for your buck?
I think the bang for the buck for the program as a whole is, again, care coordination, as you mentioned, and getting the right care in the right setting for that member. It's not rationing care, it's the appropriate care in the appropriate setting. It's not intended, care management models are not intended to be driven from reducing providers' reimbursement. That's not the goal at all. It is to get the appropriate setting. We want members to go to their primary care physicians. We want them to seek services if they have chronic conditions. So if you coordinate that in an effective way, the results filter all the way through.
Thank you.
And real quickly, I just want to mention the slide that you referenced. It's actually, that slide really demonstrates more the opposite. That's not information we're asking from the providers. It really represents information we're pushing to the providers to help them with their own practices, to identify members that haven't received necessary services, those types of things.
Okay, thank you.
Okay, Representative Stephen Meeks.
Thank you, Mr. Chairman. Way over here to your right. The question I had is I was kind of curious about this Connections Plus with the cell phones for members. Can you kind of go into that a little bit? Who pays that bill? Are you seeing abuse? Who monitors the abuse? And any savings that you achieve through the program, who benefits from those savings?
Yeah, so we pay the bills, and they're part of our complex care coordination program, only for those members who don't have reliable phone service, who have the need for the connection. It's also, many of you may be familiar with the SafeLink program, which is available. This is more of an augment for that. There are certain limitations that make that difficult. Homeless people for example, have a hard time with the SafeLink phone. They don't have an address, so it's a requirement, sometimes multiple families in a household. And so it's been extremely successful. I don't have current financial savings off the top of my head, but it's been hugely successful, and it's designed to prevent some of the abuses you're talking about. We have pre-programmed unlimited phone time to their doctor, to our 24-hour nurse call center, to their care managers, but not unlimited time to call friends, family, that type.
They're not making overseas phone calls on your dime or the taxpayer's dime?
That's correct.
Okay, all right, thank you, Mr. Chairman.
Okay, and I've got one more from Senator Teague. He's too shy to ask his own questions, but I'll be glad to ask it for him. And he brings up a legitimate concern here is obviously we have a lot of providers and physicians who won't accept Medicaid currently. And I guess the question is implementation of managed care and some of the things that come along with it, would that aggravate that even more to where we have less and less physicians that would participate? And have you seen that in other areas?
Well, let me speak to what my suspicion is in the state, is that I think if we do take a concentrated approach to working with providers in communities that maybe don't work with Medicaid today and introduce the idea and the concept of value-based contracting, that might shift some participation increase to those individuals that would see Medicaid patients. Speaking to other states, we work pretty hard in Mississippi, in the rural Delta, to recruit physicians and provide an adequate network, and it was very successful there. 250,000 lives in our program today in some of the hardest places to reach in the entire country, where there's just either very limited access or unwilling access for Medicaid beneficiaries.
So were there more physicians accepting Medicaid in Mississippi after you all than before you started?
I believe that's the case. Coming out of the gate, there's sometimes, in particularly what you may see and what we often find prior to the program actually going live, you're going to have, there's 9 companies talking today, so you're going to have 9 companies during an RFP, and you may have a provider say, I'm not talking to 9 of you. So let's see who wins. Let's see who's actually here, and then I'll come back and talk to 3. There are some issues like that, but we've not experienced a lot of problems that said, look, you're making it worse. We're jumping ship.
Okay. Okay, that's all we have on the list. Again, we appreciate you all coming and the presentation, the effort you put into. I know there was a lot of questions, but it's very helpful. We're trying to educate ourselves, and I'm sure we'll be hearing more from you in the future.
My pleasure.
Okay, folks, the next one on the group is AmeriHealth Caritas. So I think we should have Tom Lyman and Sharon Alexander. Am I correct?
We don't have many copies of those.
Okay, we're short a few copies, so you guys may have to share on some of these, the presentation that they're gonna make. Do you have it on the projector where folks can see it? I think we probably do, yeah. Well, welcome. If you all want to just, once you get your stuff pulled up there, you have to push the button on the thing to speak, identify yourselves, and you're recognized for your presentation. Again, we thank you for coming. There you go.
Great. Hi, I'm Tom Lyman. I'm from AmeriHealth Caritas. And what Caritas means is it's Latin for caring. Our former name of our company was AmeriHealth Mercy, and we were part owned by a Mercy hospital system in southeastern Pennsylvania. And After they decided they want to get out of the managed care business, they approached their partner, which was Independence Blue Cross, which is in southeastern Pennsylvania, and which operated through their AmeriHealth subsidiary. And then Independence Blue Cross contacted Blue Cross of Michigan, and they formed the partnership. And why the name is important is we were started as a hospital-based program, provider-sponsored, and in Philadelphia in 1983. And the reason was the hospital system wanted to keep its primary care practices close at hand and not be absorbed by the big health systems in the city. And at that time, it was before medical home became in vogue. We like to think that that was one of the first medical homes because that was where the focus was around primary care. As you see on the slide, the Who We Are slide is just a little bit about the perspective and the companies that you heard before us and after. You're going to hear a lot of the same themes. Where I think we're a little bit different is because of that mission orientation of starting out by a for-profit hospital system, and then we're owned by 2 not-for-profit Blue plans. Even though Representative Meeks, we compete with local Blue plans, a la what the AmeriGroup said, but we also approach them and do partnerships. And some of the things when I hit the map shows things like that. So if a plan wants to do it, we work with them in some cases. We also work with provider groups and others. So we get a little bit of a different perspective based on that. As you can see, we serve the same type of populations in both urban and rural settings with Medicaid, variety of categories of aid with Medicaid, moms and kids, AIDS, blind, disabled, also dual eligibles, CHIP programs if it's carved into states, and part of it is also something we're experienced with. We have a behavioral health solution that supports our physical health as well as pharmacy benefits management, and a lot of the discussion earlier this morning about the high-cost pharmaceuticals. We also have a specialty pharmacy solution that tries to address that, and we'll keep that in the care management. You heard about model of care. We also have done that and established that, especially in the states where we have AIDS, blind, disabled, or the managed Medicare and Medicaid. And we touch the lives of about 7 million folks. And again, our mission is, helping people get care, stay well, and build healthy communities. And we really feel like we do that. All the discussion before about getting in and getting up boots on the ground and being community-oriented is really what we've seen as being is the most successful way to do managed care right. This just is a map that shows you some of the different states that we're in, and some of them would, may have some similar challenges to Arkansas, including Louisiana and South Carolina. We started out in South Carolina many years ago, and there was a lot of concern from providers who were nervous about how the effects of managed care on their practices and the effect on small hospitals of going out of business. And we really, in South Carolina, we've been operating since 1999 and had not really seen any kind of that negative effect. And one of the things I would recommend is, as you're hearing, in some of the conversation about talking to physicians, I'd recommend Mr. Stevens, talk to some of the primary care physicians in South Carolina who have, and especially the federally qualified health centers who have absorbed and actually flourished under a managed care model. And I forget who it was that said it before, it was right on target. As you look around the map, it truly is, you've done one Medicaid managed care, or one Medicaid program, you've done one Medicaid program. I thought John Stevens' slide that showed all the varieties in the different states also said it. One of the things that we have done over the years, our company has adapted to each of those by doing either standalones, where we own the managed care organization outright, like in South Carolina or Louisiana, but we also do joint ventures. I mentioned Blue Cross. We have a joint venture with Blue Cross Blue Shield of Nebraska. We also do services for Horizon, which is the Blue Plan of New Jersey, and we do support for Blue Cross Blue Shield of Michigan in the state of Michigan. And then we've supported provider-sponsored groups in Kentucky and in Indiana, in some cases competing with some of the other folks that will be here talking to you today. I'll just, I'm not going to go through for this, for purposes of time, but our experience is similar to some of the others in the doing the dual eligible and MMP, where you have frail elderly, adults with disabilities, and other challenges that really need that kind of care coordination model. And then we also have the traditional, the DSNP, which is a special needs plan for Medicare that serves also folks that are also eligible for Medicaid. And then a lot of the focus of your RFI was around behavioral health. We have our own behavioral health solution and a pharmacy solution that we found that helps us integrate the management of the of each of the individuals, and also gives more information. One of the things that are challenges for primary care physicians specifically is getting all the data they can out of their on their particular patients. And I think integrating it and having provider portals, for example, that I think all of the companies have that can push that information out, has been a benefit of managed care because they get more information about pharmacy and behavioral usage than they normally would have. All right, this when we looked at coming today and we were asked, we just thought that we had some ideas on, and especially since I've been around my company since 1991, and listening to you talk about, one of the representatives was saying about the 90s with HMOs and in different states, and I saw a lot of that, and I thought hard about what would I recommend to you all that would be to avoid some of those problems. And I think some of the things that you talked about today is, well, just the fact that you're doing this. I was trying to remember a case where the legislature was actively thinking about options early on and helping actually to design the program, and I really couldn't come up with any. A lot of times it's done because of a cost issue in a particular year, something's pulled together quickly, and then that's where some of the problems and the challenges happen. You mentioned a couple of the states right away. I remember Tennessee in the early days in TennCare in the beginning, before it's sorted out with the companies that are there now, was an example of that, of doing something that really didn't have a precedent. As you can see on the slide that we've put up here, some of the four areas that really are, if it's done right and it's designed right, can actually increase access. The previous conversation was about when we've gone into states, we've seen that too, where actually physicians and specialists that may not serve Medicaid before actually come and will work with us to develop programs. And the value-based programs that that were also discussed, the shared savings and the quality-driven portions of it are another attraction. We're seeing in some states now, other states that are considering managed care, the big systems are actually reaching out to our company and some of our competitors to talk about how could they get involved in that. I think you saw on John's slide about accountable care organizations, the ACOs, more and more are being embedded in the programs. All of the things that were talked about in Dr. Ron's, I think, presentation, the medical home, episodes of care, are actually components of a lot of other programs, especially around providers. The quality, was mentioned the NCQA in the previous presentation. As you're designing the program, I think you want to ensure that the bidders all have that. We call that the Good Housekeeping Seal of Approval for health plans because of the requirements that go in for it. You took a theme you just mentioned about with the care coordination. That is something that's been, I think, I would agree with the point that it was a really big part of the success of the organizations that have been in business for many years like ours. And the financial is, why managed care, why do it versus doing it yourself, is the budget predictability and having to operate within that budget. And it also forces you to be in a true partnership with the Medicaid leadership and the state stakeholders, as I mentioned, as and the final point that I want to make is when my kids ask me why do you do what you do and why have you done it for so long, is the success stories advocating for folks who need help to navigate a system, whether it's a a teen mom, or if it's a family that has a child that has three comorbidities and is a wheelchair-bound, behavioral health issues, et cetera, is we've really seen that you make a difference in helping and supporting the states to do that. So that's my, well, wasn't too long.
No, appreciate that. You know, and I don't know how much of this you want to share, but one of the presentations that we hear many times when we talk about managed care as well, they're going to put a 15% management fee on top of the cost. And so until they cut 15%, you're at a revenue neutral situation, because you guys have to go find 15% to make it where you can save us any money. And I guess what I would ask you is, do you feel like that's accurate? Do you think that is that about the standard margin for MCOs to come and manage those organizations? And of that, do you agree with the premise then that you have to find 15% beyond what the state could do itself?
Well, we would have gotten out of the business a long time ago if we had maintained just 15%. In some states, we have to operate with 10 or less. And part of that reason is because, and especially if you've got the AIDS blind disabled population in, which is very high cost, and that 90% would call the medical loss ratio, you have to be able to manage within that. So we've had some cases where, we've operated on margins that may be less than what some other companies have required. And part of that was because of our mission. I remember in Philadelphia a number of years ago when the AIDS blind disabled was mandated in, and then the pharmacy we almost went out of business until we figured out how to manage it, because we weren't going to take our networks and not serve the people who serve the folks with sickle cell, or not serve or not have the providers who serve people with hemophilia, as some of the other companies did at that time. So I guess we figure out a way to manage it, and that's where I think a lot of the programs
I guess
develop.
similar to the question that my co-chair asked earlier today then is, you all know what the costs are from your experience in other states. We've got if you include the expansion population, a $6 billion program here. If, as policymakers, we said our intent is to maintain the cost curve flat or less than 2%, you're comfortable that through managed care you can find 10 to 15% margin, or whatever it is you all have to have for administrative costs and overhead and profit, and still meet that kind of cost curve reduction?
Yeah, we've done that within the states. Mentioned capitated before. It's just really a PMPM. It's a budgeted amount. We've operated within that, and we also, for example, in Iowa, we were one of the companies that was selected. So we looked at the rates that they gave, and we feel like we can manage with that too. And they've got certain targets, the state does, of cost reductions as well.
Okay, Representative Meeks, you're recognized.
Thank you, Mr. Chair. My question, I'm not sure if you're aware of this right now, but Arkansas has about a 2,800 person waiting list on our disability services and everything. And I noticed that you have programs that include adults with disabilities, intellectually disabled, and everything of that nature. Does your company have any experience with waiting lists in other states? And if so, or even if not, is there a proposal or something that y'all are doing that may help to get that waiting list, or making sure that all people are able to get the services that they need?
Good morning. Let me introduce myself. I'm Suzanne Bostic. I'm the Director of Long-Term Services and Supports for AmeriHealth. And my business focus is on long-term services and supports and working with people who are aged, blind, and people with disabilities. We currently, as Mr. Lyman said, we currently are working with 2 states, the state of Michigan and South Carolina, in a model called dual demonstrations. It's a federal demonstration that CMS has offered to a number of states to manage both Medicare and Medicaid expenditures for this population. In Michigan, we're working with the aged as well as individuals who have a physical disability, as well as individuals who have a developmental disability. In South Carolina, we're focusing on the frail elderly. And in those states, there are existing home and community-based waiver programs, which are provided under the Medicaid program, have existing waiting lists. And states have been trying to figure out how to eliminate those waiting lists, but it requires extra state dollars and extra federal match to open up spaces in the home and community-based waiver program to serve those individuals. What we are able to do under the capitation payment is to serve additional individuals because of the savings we can achieve through transitioning those people out of institutions, avoiding an institutional stay, reducing hospital stays, and serving people more effectively in the community. So in order to affect those waiting lists, you have to be able to find those savings that allow you to open up opportunities and revenue to serve additional people. It is a challenge across the country. There are hundreds of thousands of people across the country on waiting lists for home and community-based services in existing Medicaid programs. It's why you saw in Mr. Stevens' slide that so many states are now looking to a managed care delivery system for long-term services and supports. It's because the existing fee-for-service system can't support those waiting lists.
Thank you, Mr. Chair.
You know, here's the circle I'm trying to square, or the square I'm trying to circle. On the one hand, we're hearing the way managed care companies achieve great outcomes and saving money is by a different healthcare model. And the different healthcare model is not about punishing people on rates. And that creates better outcomes and savings to the states. And we're seeing a dramatic number of states pursuing a managed care model. I was stunned to find that it's, you know, well over half the states are doing it, and Arkansas is in a small handful that's not. On the other hand, I hear day in and day out from individuals here that are involved in the medical system that all the managed care company is going to do is cut my reimbursement by X, pocket the money, and nothing else is going to change. And so the thing that's got me scratching my head is normally the marketplace will kind of sort out, you know, which of those two theories is accurate. But we've got managed care going in all these other states, and yet the providers that talk to me in our state are not saying, oh, I've seen what's happened over there, I'm really not nervous about it. And then when I look at our state, we've got our payment improvement initiative, and again, I don't want to be, you know, overly negative about it, but when our consultant reported on that, you know, it certainly wasn't blowing the doors out. So I'm just really scratching my head on how to take this cognitive dissonance and try and understand what is reality. Do you have any insight that can help me understand those conflicts?
Well, it's deja vu. We've heard the same things in Louisiana when they had a PCCM program and moved to full managed care. Again, I mentioned it happened in South Carolina, also in Arkansas. And if you talk to a lot of the providers that were very concerned at that time, especially some of the big systems, they've changed because they've seen now that the managed care plans not are just about denying days and reducing stays. It's sharing more information.
Let me just take the statement. So the provider, So if I go get the head of the doctors group and he comes in my office right here, I'm pretty confident what he's going to say. And you're saying if I went and got the head of whatever the doctors association is in any one of these other states, that group is going to say, hey, we're, you know, rah-rah-ree, this is working? Are you sharing that? Is that kind of what you're saying to me?
I'm not saying it'd be rah-rah. It would be, it's different, and it might not be as bad as they thought it was. I think some of the theme that you see is people, a lot of the physician groups in the hospital systems feel like the managed care company is telling them what to do. And that's why you have to do a lot of education with it and talking to them about, no, it's not necessarily that. I just saw recently in another market, though, when managed care was coming out, a large accountable care organization came to the different vendors and asked and basically put out a request for information. How do you approach it? So they accepted it, that this needs to be done, and then they're adapting to it. But there's no incentive right now, there's no positive for some of the provider groups in Arkansas to go after it, just because it's an unknown, and someone's going to be, in some cases, maybe 2 or 3 companies will be telling them some different things that they have to do.
Okay, Senator Ingram, you're recognized.
I've forgotten my question.
I often have that effect on people.
I'll leave that alone. You mentioned earlier about the waiting list that we had. Were any of those states, had they adopted CFCO?
I'm sorry, CFCO?
Well, the home-based Medicaid.
Community-based
Yes.
care? Have any of those states? Yes. I think, as you saw from Mr. Stevens' slide, and Pennsylvania and Tennessee are two very good examples of them. Tennessee had very large waiting lists, especially in their aging, disability, and their IDD population. And many of the states, I'm trying to think of the states that I know right now that are doing what's called managed long-term services and supports, had existing waiting lists in their waiver programs, in their current Medicaid programs.
And I assume the ones that you've tried to work with that haven't still have waiting lists.
Well, the states that we are working right now with managed long-term services and supports, South Carolina and Michigan, we're engaged in conversations with other states, both have waiting lists in their waiver programs.
And the other question, just anecdotal, y'all are in Louisiana, and I see y'all have pharmacy benefits there as well as managed care for behavioral health. We've noticed that Louisiana has had double-digit increases in their premiums versus Arkansas. Any observation of why that is?
When you say premiums?
For their insurance, for their people in their states. Haven't they had, they're 18 to 20% increases?
Yeah, I can't speak to the commercial insurance increases because we're on, AmeriHealth Caritas and our competitors are on the fixed budget that is done each state, and that's, I know there's not been not to my knowledge, been double-digit increases in the Medicaid rates. I'm not sure what the effect is on the commercial side, Senator.
Thank you.
Okay, that's all we have on the list. Mr. Lyman, Ms. Alexander, thank you all for your presentation and coming down. We're going to hear from one more before lunch, so if the folks from United Healthcare, Catherine Anderson will come down. We will. Well, welcome. You get the best spot right before lunch, and it won't be too many hard questions, so we appreciate you coming. If you would state your name and who you're with for the record, and you're recognized.
Absolutely. Thank you very much. And I will be brief because I hate being the person that stands in front of lunch. My name is Catherine Anderson. I'm National Vice President for State Programs for United Healthcare Community and State. I have responsibility for working with states like the state of Arkansas and helping find solutions for their Medicaid populations. Instead of spending a tremendous amount of time on who we are, I will give you a brief overview of who United is. I wanted to spend time with you on areas that I have worked with states on that I know are some of the most complex questions that states often have in developing their programs. Some of them have come up. For those, I will try to be brief in providing some additional color, but others we've yet to discuss, and so I want to focus my energy and time with you on that. United Healthcare Community and State is part of United Health Group, whose mission is to help people live healthier lives and make the healthcare system easier. United Health Group is comprised of two businesses, United Healthcare, which is a benefits business that has commercial, Medicare, Medicaid, military and veterans programs, and Optum, which is a services vendor who provides robust service solutions, including data analytics, clinical programs, and specialized services. United Healthcare Community and State is the organization within United Healthcare that's dedicated to serving Medicaid beneficiaries and individuals who are dually eligible for Medicare and Medicaid. Today, we serve more than 5.4 million beneficiaries in 25 states. Of those 25 states, 23 of them are Medicaid contracts, and those really range the entire scope of beneficiaries, similar to some of our competitors, from infants to end of life. In each of our programs, it's safe to say that there are complex individuals who are served in Medicaid, whether it's in a TANF program with infants who are born with significant challenges, all the way through our aged, blind, and disabled programs. However, of our programs, we have 12 contracts that are specifically dedicated to complex populations, and we've been serving that population for more than 30 years. We believe very strongly and have a long track record of working with states to develop a program that's unique to the state's needs. I won't repeat the saying that's been said several times about the uniqueness of Medicaid programs, but I think it's really important to note, especially when we start talking to states about complex populations, each of the programs is very different. So for instance, in some states, one of the primary goals was to achieve no waiting lists. And if that is the goal of the state, there are specific things the state can do to structure the program to achieve that goal. Other states, like the state of Tennessee, one of the primary goals when that program was started was really to move more and more people out of institutional settings into community settings. And so we have a long track record of helping states understand what are the primary goals of the state and how to structure programs that meet those goals. Based on our experience of more than 3 decades, we know what works well in complex programs and what doesn't work well. We will tell you we've been with states at the beginning of programs where the design, whether it's truly just the design, the included populations, how they expected us to work with providers, how the rates were structured, et cetera, that didn't work well. And through that, our experience, we've developed some core elements. We actually call them our essential elements in helping states understand what are the important things that you should consider when you structure your program. And I'm just going to highlight a few of them. First, comprehensive population. So ideal models, in our opinion, include all Medicaid populations. That gives you the best scalability and the best predictability and sustainability for your Medicaid program. However, if states like the state of Arkansas want to focus in on specific populations, that certainly can be done. What we would recommend is that you try to have as broad of the population as possible. So let me give that in plain words. Instead of just having people who are eligible for long-term services and supports, either living in a nursing home or living in a community, we would encourage you to consider the entire age, blind, and disabled population. That affords the state the opportunity to plan for and identify individuals who may be at risk of needing higher intensity services 12, 24 months out, and allows us and requires and incents us to identify those individuals and provide services to avoid the risk of institutionalization in the future. This was already touched on briefly before. We do think comprehensive benefits are important. Carve-outs should be avoided because, as was stated, we are all whole people and should be treated as whole people, particularly when we start to look at these complex individuals. It's very difficult to say that a person's physical health isn't related to their behavioral health, isn't related to their pharmacy needs or their social service needs. So it's very important to have comprehensive benefits. Another essential element from our perspective is strong stakeholder development. This is certainly part of that, and we applaud the state in having these forums for people to provide insight and experience. And that is important during program ideation all the way through implementation and long-term to ensure that stakeholders, broad group of stakeholders, members, their families, providers, interested advocates, have an ongoing voice in how the program is structured and run, and have a voice to provide feedback when things aren't running well. We also believe that rate development is important to align incentives and to achieve the state's goals. And I'll get a little bit more into that detail in a moment. Another thing that's really important, questions have come up already today about quality outcomes. And one of the things that I would say is very important in considering a program design is that you create quality structure that's very targeted to the population you're serving. So as an example, this is a real life example, I won't identify the state. In one of our managed long-term services and supports programs, we are held accountable to report on well child visits. No children are included in the program, however, it is a quality measure that we report on. That's an extreme example of why it's important to make sure that the quality program, what you're measuring managed care against, is really structured to the population that's being served. The other thing that I think is important from program design is to ensure that there are incentives that are in place to encourage the expansion of progressive primary care relationships and value-based purchasing. And some of this conversation has already been had today, but it's important to understand that these models don't necessarily fall outside of managed care, and in fact, managed care can be used to further the process of moving to value-based purchasing. And one of the things that I think is important to speak to, especially in a state where you have made investments and there already is infrastructure around PCMH and health homes, is that value-based purchasing can be, in a managed care environment, can be expanded far beyond what you see today in organized PCMHs and health homes. Through many of the programs, incentives, contractual relationships, tools, and other resources, we're able to actually help providers who are smaller providers, perhaps a standalone primary care provider in a rural community, take on more responsibility that results in both tools and techniques to better manage their population with additional data, as well as reward for outcomes as that provider improves and fills gaps of care. A few other things just to focus on quickly is that it's really important to have a strong care management program. But that's not all that managed care brings to the table. A question was asked early about, well, why can't we as the state just do care management? I think it's really important to understand that what we do is more than just care management, and even the care management is probably more than you can picture it being, because it is more than just a person on the phone answering questions and making decisions about the care that an individual will provide. There are many things we bring to the table, such as data analytics, predictive modeling, robust clinical programs and structure that we bring that is more than just the state taking on care management. And I think it's important to understand that when a state moves to managed care, you're really looking to a specialized company that has been structured in order to do these services. You wouldn't, in other kinds of purchases that the state makes, you wouldn't assume that the state would provide those services at the same level as a specialized contractor. And so I think it's important to think about that in terms of moving to managed care. The other thing, just briefly on the on care management process, and then I'll pause for questions, is that care management in these models is very much done locally, as many of my competitors have already said. This is done in people's homes. In some instances, it's actually done on the street for homeless populations. It's done in group homes, it's done in adult daycare. This is not a telephonic model. So that has two things to impact for two reasons. One is it provides the best outcomes, but it also creates an employment opportunity for care management in individual communities, because the individuals who are hired to do care management are hired from the communities that they serve. The other thing that's important is it's not just a person making decisions. I think that is always a concern, that you'll have someone that's going to make decisions about an individual's care. It's actually, in our model, is an interdisciplinary care team, and that is a broad group of individuals that include the member themselves, their family members where appropriate, their primary care provider, and any other specialists, including specialists like pharmacists, behavioral health specialists, et cetera, who might be able to help that individual achieve the goals that they have for themselves. That process and that team works only based on an individual's needs, and that is determined through very robust assessments, and that's an important thing. These are not arbitrary decisions that are made about an individual's care. It's about understanding through lots of tools that each of us have to figure out what an individual wants, what they need, and then wrap services around them in an individualized plan of care. And I have many other things, but in the interest of lunch, I will pause and see if you have any questions.
Okay, let's take questions. I have a couple. First one is, I see you're, United, according to the grid here, is involved in over 20 states. Can you point to a state where our consultants could look, or the task force could look, and demonstrate that managed care has moved a state up in the health rankings with regard to their health performance? In other words, moved a state like Arkansas from 49 to 39, and also either reduce costs, maintain flat, or change the cost curve. If you were going to pick a state, what would you suggest we look at as far as performance of managed care in those two areas?
So the second part is easier than the first part. The one thing before I answer the question on the specific state, the thing that to keep in mind, in order to really successfully do both well, you need to have a broad population in managed care. So if you only have, for instance, 100,000 people that you move into managed care in these specialized populations, it will be very difficult to move the needle, particularly on your health rankings. So the important thing from a health rankings perspective is to have as many people affected by it, an improved system of care as possible. So that's an important thing that I think is important.
I think Arkansas is at about 1/3 of the population on Medicaid.
Yep, so if you move the entire population into managed care, you have a better chance of moving the needle on your health rankings, quite frankly, than if you do a subset of the population. Now, the RFI and the conversations to this point have been on specialized populations, so I think that's one of the things that you'll have to think about, again, to the goals of the state, how important are those specific goals, and if health rankings, improvement in health ranking is something you want to achieve, then you have to think about a broader population. So in terms of moving bending the cost curve, many states have bent the cost curve. I would point to Arizona as the longest standing managed long-term care program. It's more than 30 years. They have continued to show system improvement year over year. They continue to reduce the number of people who are reliant on institutionalized care year over year. They're going to be able to show you what happens to the cost curve. One of the challenges, though, because of the length of that program, is that what are you measuring against after 30 years? So I would say another opportunity would be to look at a newer program. Tennessee is a good program. I know there are questions about the data, and I think that can be easily handled between the state and the consultant. But the other one I would say is Kansas is a great example where they are starting to show, again, new program. KanCare is a relatively new program. They're starting to show leveling off on the cost curve.
Okay, and my second question is, again, with regard to the concern that Senator Teague brought up about physician access and physicians buying into this. Since you are involved in 20-some states, what is your experience with access for Medicaid patients to physicians when something like this occurs?
So we're in a somewhat of a unique situation as compared to some of the companies you've heard from, because we are part of United Health Group and because we have large networks in every state. We serve commercial populations, Medicare populations, and military populations in many states. So two things come with that. We have relationships with large provider networks in the state, many of which would not be interested historically in providing services to Medicaid populations. Because of our relationship with those providers and our contractual negotiations, we're actually able to expand the number of providers who are in our commercial network, as an example, to serving individuals who are in our Medicaid network. The other thing that I think is really important in terms of access is, and this was touched on a bit, but I think it's important to emphasize, is that for those providers who are already serving Medicaid, there are many things that we can do to actually make it easier for them to serve even more. And those could vary from helping with some tools, helping with technology, as well as bringing resources such as care managers into their practices so that they are co-located in the practices, which frees up the practice staff to do good primary care. There are always, I think it's important to note, there are always very specialized specialists who are somewhat challenging to get in network because they don't have to. Quite frankly, we would use them anyway. We've had a great success actually in getting contracts with providers that historically would have stood outside, and again, part of that's because of who we are.
Okay, Senator Ervin, you recognize.
Thank you. Question, and really, Mr. Chair, it's a kind of a question I think for all of them is the question that was brought up about lawsuits and being sued and suing states and things like that. I think that's a question that I wish every one of them could ask. Have they been sued? Have they sued the states before?
Let me just respond to that. We're going to have that as an agenda item for the September meeting about, and the Stevens Group's going to bring us some information about the impacts of lawsuits, both in managed care and also at emergency rooms and other things.
Okay, thank you. But my question specific to yours is talking about those. You say there needs to be some extra resources brought in, and that, but why did there need to be extra resources? Have y'all the reason I say that is there's so much being put on to particularly your smaller practices that they're very it's difficult to do it all, and I think that's missing in it. And so is your approach in negotiations, because I use that term because sometimes negotiations aren't really negotiations. They're you either do it or you're out and you're going to lose all your patients. And so, yeah, that's concerning to me. Is how do you manage with that with your patients or with your doctors and your providers, and why do you find that you see that a lot in primary care settings?
So I will answer your question. I'd like to highlight something, though, that I think is important to consider, and several states have done this recently because of the concern of the negotiations that, and this is a common concern that we hear with providers, that the big managed care companies are going to come in and strong-arm us, and we're not going to have any negotiating room, and it's all going to be about rates. And I can tell you that's not, in fact, how this works. And when managed care companies attempt to do that, it will blow up in their face. But there are things that the state can do to actually create an environment in which you kind of take away all of that noise. So things like any willing provider participation for a certain period of time in order for the providers to get to know the managed care organizations and vice versa, as well as establishing of a rate floor, which is typically the Medicaid fee schedule. So there's no incentive or no ability, quite frankly, for managed care organizations to negotiate underneath it. In fact, if the procurement's structured correctly, there's incentive to go above. So I just wanted to take the time to do that. To answer your question specifically, many of the challenges in serving this population, and particularly the complex part of Medicaid, the populations like those individuals in need of long-term services supports, intellectually and developmentally disabled, et cetera, they have so many needs that go far beyond why they're in the doctor's office to begin with. And many, what we hear from practices in serving this population, that in addition to, filling out the claims and managing their schedule and making sure that they've got enough people to help their patients to see their medical needs, they're getting bogged down in managing some of these other complex situations, like their power was turned off this morning, or they can't get food. They don't have a house to go to. That's where managed care comes in. Our role is to quiet, if you will, the noise around the delivery of care, create a plan of care that's individualized to that person, take away that noise so that when they're in the provider's office, they're actually meeting with the provider for the things that the provider is best suited to support them with, instead of getting caught up in all of this other stuff that, quite frankly, in an unmanaged market is really the responsibility of the beneficiary to solve on their own.
So, and last thing, so procurement is key.
Procurement is key.
Okay. And then secondly, as I have often spoken about, and a lot of people have, managed care has a lot of different definitions.
Yes.
So what you've just defined is something different than managed care on payment, managed care on all the different, care coordination, but you've identified a different managed care type of a setting. So I think that's important too, in looking at all the different vendors and companies that are presenting what their definition of managed care is and where their specialty, I guess, would lie, and then how those needs would fit up with our state. Thank you.
Okay, Senator Bledsoe, you're recognized.
Thank you, Mr. Chair. I heard you say that for a certain period of time, there would be any willing provider. So do you have a cap of the number of physicians that you could employ if you get into this managed care? And is it the first 35 that say, okay, I want to do it? Or how does that work? And I'm talking about narrow networks as well as any willing provider.
Absolutely. So there are benefits to narrow networks, and there are benefits to any willing provider. Any willing provider provisions are typically employed by states at the beginning of a program to avoid the disruption that people fear managed care would bring to the marketplace. And states that employ the any willing provider provision, it's typically done on a subset of providers. So you wouldn't have every hospital, for instance, be an any willing provider, nor would you have every cardiologist. Those are providers that really should be considered as part of a normal network access conversation, and they're far more accustomed to dealing with insurance companies, quite frankly. The states that have employed any willing provider provisions, it's really on specialty providers, particularly around LTSS, long-term services and supports, and home and community-based services. Those are providers who are less comfortable and less familiar with working with an insurance company. And so states, Tennessee, Florida, Delaware, those are off the top of my head, I probably could come up with some others, used any willing provider provisions for the period of time as the program came up to quiet the noise and help the system transform over time. Each one of them had an end to that. It differs by program. Some are as short as 1 year.